Okay. So there we go. Okay, so can you see that okay on there, Kim? I'm trying to show.
I can't even get in right now.
You can't get in?
No, you don't have the camera on.
Oh, you guys, you'd think it was Monday.
They can be Monday. I don't know.
I can read you Monday.
I could redo Monday.
I've got vision.
High def. Okay. Now we'll see if you can see it. Will you ask her to turn the camera on? Thank you, Megan. Okay, now can you see this? It is a grid I have found was really helpful. A student said about 4 semesters ago, if we had a way to break down the heart anomalies and things that were the same and things that were different, because you will find that all of those babies have trouble feeding, and all of those babies are kind of skinny, failure to thrive-ish kind of babies. All of them get too tired. And so you start going, I don't even know how to differentiate this, right? But then you find that coarctation has blood pressure issues, and that high-pitched machine-like murmur below the clavicle goes with an ASD, or some of these real pinpoint different things. So I started this grid for you guys to be able to put down the heart anomaly and the signs and symptoms, and then you can go through and highlight what was different. So you could see that care of a baby that has a heart anomaly is pretty straightforward across the board as far as giving them time between feedings, letting them rest, clustering your cares. Some of those things you'll find come out in the presentations pretty routinely. But then you'll have some things that are different that you can highlight. So there's 3 pages. It goes through all of the heart anomalies. So I kind of gave you some examples at the beginning, left you a little more room, and then at the 3rd page, I left you quite a bit more room. So you can fill it in and use it as a study guide. Okay. And then I will give you, if you're in class and you have a printer, bring. It says cardiac learning activity, I believe, and it's just this here, and it's just a fill in the blank, and you can use it as the presentations go along, and it will help draw out some of those individual things too. Okay, I will have some copies with me though if you don't happen to have a printer. Did everybody get the 3 handouts that were up here yesterday? The colored grid and the little cheat sheet and stuff. Okay. The grid, fill in the blank. Quiz, we're good. Okay. Oh, I have a joke. We can't forget that part, right? So there's this nun, and she has been out serving our community, and she's walking back to the convent, and she really has to go to the bathroom. So she stops at Hooters, and as she walks in, she hears this really loud music, and everybody's having a really good time. And the lights go off and flash back on, and everyone cheers. And she's really confused. And then they notice her, and it gets really quiet. And she walks up to the bartender, and she says, do you have a bathroom that I can use? And he says, yeah, but I have to warn you, when you first walk into the bathroom, there's a statue of a naked man that only has a fig leaf. He's only wearing a fig leaf. And she says, oh, that's okay. I'll just turn the other way. I'll be just fine. So she goes to go to the bathroom. She comes back out, and everyone cheers. And she's like, what is happening? So she goes to ask the bartender, and she says, why is everybody cheering for me? I just went to the bathroom. And he said, well, you see, there's a sensor on the fig leaf, and anytime someone lifts it, then the lights go off. And he said, how about a drink? Can you imagine being that nun and being like, oh, I'll just turn my head the other way. And then you come out and everyone cheers for you. So I can't remember who it was. A student told me that one and was like, they had a similar experience of someone. That's why when they saw that joke, they're like, this is amazing, because they had been around somebody who had been a priest or something like that, and then was busted with like child pornography or something like that. And he's like, well, I guess any walk of life is subject to those kinds of things, right? So then he's like, so I have a joke for you. All right, so we're gonna go to slide 64. So I'm going to share my screen here. And then okay, do I have, Kim, can you see that way on there? Okay.
Well, there's a slide that's coming next as well, so.
Yeah. There we go. Okay, we finished. We were kind of in a hurry with AFib, so I thought we'd start here because I think we were actually on the next slide. But it originates in the atrium. The rate is variable, so that atrial rate can be really, really fast. Actually, you'd be unable to count it. Your rhythm will be irregularly irregular. Do you remember what I said about AFib and A-flutter? The atrial fibrillation, about 95% of the time, it's going to be irregular. Atrial flutter, and we'll get to that slide in just a second, same, about 90 to 95% of the time, it's going to be regular. So if you're really sitting the fence on which one it is, look at your irregularity. Yeah.
So is it regularly irregular, or would it be irregularly regular?
Irregularly irregular, meaning there's no pattern.
I know, but
So you
A1.
can just say it's irregular.
Okay, so then A1 would be regular?
Mm-hmm.
Just regular.
Yeah, like a regular rhythm.
Oh.
Yeah. So you have a very set rhythm to it, as opposed to this where it's just kind of all over the map. Your P waves, you have many small fibrillatory waves because it's not contracting. It's just fibrillating, like it's just shaking. So you get all these little P waves. And then your PR interval isn't applicable because that's the interval between the T and the QRS. And you have all these P waves before QRS finally gets through. The QRS is narrow because it's coming from the atria, but not coming from the ventricles. So anything above the ventricles is going to have a more narrow QRS.
Can you just move the computer a little bit so we can actually see what you're talking about?
Oh, yeah. Okay, tell me. Better?
That's good.
Okay. Your ST segment and your T wave aren't going to have any changes, and your T wave will be difficult to see with all the P waves. Sometimes it's big enough and round enough that we can differentiate, and other times it kind of gets lost in the P waves. So we talked about a lot of the causes, particularly like alcohol and carbon monoxide poisoning. We would have patients coming in ED that had been binge drinking, and now they were having AFib, an AFib dysrhythmia, and until they started to metabolize that and kind of come around, and their blood alcohol went down, then they would still run that rhythm, and then it would start to just self-resolve. So it can, unless it's increased age, kind of idiopathic, they don't know what's causing it, then it doesn't always just change, doesn't always end. But if they can resolve like pericarditis or hypoxia, then they can usually resolve the dysrhythmia. What's that?
Sounded a funny thing.
Oh, did it? I thought it cut out for a second. I don't know. We're gonna see. They promised me they would get it like figured out in the AV system or something like that, so that it would be like a big classroom that we have when we did peak sim. We just have to have a little bit of time to do it. The congestive heart failure, coronary artery disease, and hypertension. If hypertension is the cause and they are taking medications, then that can help. But often, because these are more chronic conditions, they will end up having an AFib dysrhythmia chronically. Okay, so what's your rate? 80, okay. And then we're going to check our rhythm. So there isn't a pattern there. If we go here, then it's kind of irregular there. If we go here, then it's, so there really isn't a pattern to it. Okay? So we'll just say that it's irregular. What about your P waves? Do you see one before every QRS? Or do you see many? Yeah. Yeah.
But it's the last one, so.
Oh, that's okay.
So, you supposed to put in the promising, but not that sometimes you said you recommend
They can. And that's coming up with the treatment side. No, but that's good. That's really good. It's a good lead in. Okay. So you have lots of these little P waves that are going through here. Do you have a narrow or a wide QRS? Narrow. Okay. And what about your ST segment? Comes right back to that baseline pretty good. So we don't have any issues there. Can you identify a T wave? Probably this one that's a little bit bigger and rounder, and then you have all these little P waves. But look here, you have what looks more like a P wave, and that is awfully risky, really close to being on a T wave. And sometimes when those land together, you can end up with BFib, like you can knock them right into a lethal dysrhythmia. Right here. Oh, where it's almost together there? Yeah, so you can really get into trouble when you have AFib and you have a really fast atrial rate. Yeah.
So how can you tell when they go together then?
How can you tell when they go together? You mean like this?
Yeah, because you said that they're like, it's not quite together yet, so like.
Well, see how you
know?
can see kind of a P wave and a T wave? The T's are usually a little bit bigger and a little bit rounder, but sometimes you won't be able to see the T waves. It all will look just like this. And so then you would just say that you can't see the T wave.
The T wave gets over.
It kind of gets meshed in there, yeah. So could it be that the P waves are landing on the T waves? Yep. And that makes it really risky. Sometimes some people are very susceptible to having for throwing into a lethal dysrhythmia. A lot of times with AFib, they can control it with antidysrhythmics or an ablation or a few things like that we'll talk about in just a second. But yeah, sometimes you can't tell. But I won't ask you to identify a T wave in a slide that I'm looking more for AFib or AFib. Okay. I just am getting you in the habit of walking through each step so that you can identify your rhythm. That makes sense? Okay. So we've gone through everything. We've gone down to our T waves. We know that it's irregular. And so what would you call this? Just? So it's irregular. And we've walked through all of our P, QRS, T, and there's nothing else wrong with it except for all these little T waves. So it would just be atrial fibrillation. Okay. So if you look here, this is kind of comparative, I guess. You would be able to see that you have one P before each QRS. Your ST segment comes right back up here, and then you have a T wave. And so you can see how it's just got this nice pattern. It says normal sinus rhythm, but in this 6-second strip, if you were to count it, it would actually be very pretty. But then you're looking down here, and you can see all these this wavy baseline. Sometimes, if they have the amplitude turned up, they call it coarse atrial fibrillation, where you really can see it like here, where you can see it quite a bit. This is more of a fine atrial fibrillation, where it's just barely fluttering, just barely fibrillating. It's just shaking just a little bit, as opposed to really shaking where you're getting the bigger waves. So if you see one that just kind of looks like this wavy little bumpy baseline, that's still atrial fibrillation. It's just not fibrillating a lot, which is oh my heck. Anyway, so then you still have your narrow QRS here, and you're still, now your ST segment, if you looked at your isoelectric line, it's still doing okay, comes right back to baseline. So your only thing that's really wrong with this is the atrial fibrillation. But I wanted you to see kind of the difference between one that's a little more coarse and one that's a little more fine. All right, so signs and symptoms. There's no effective contraction by the atria. It just quivers or fibrillates. So you have a decreased stroke volume and decreased cardiac output because you don't have an atrial pit, right? Remember, you can have passive filling from the atria to the ventricles, but as soon as that atria contracts, then it shoves more blood in there. That's that atrial pit. If it's just fibrillating, we're not getting good blood flow into the ventricle, which means we're not going to get good blood flow out to the body. And so you're going to have a decreased stroke volume and decreased cardiac output. About a third of patients will develop emboli. Why? Why do you think that happens? Because their blood is what? It is. It's stagnant. It's just kind of like sludge. It's just sitting in there like this, just kind of shaking around a little bit. And then all of a sudden we have an effective contraction. And then what happens to that emboli? Travels, right? And we have big problems. So, so we'll get to that in a minute right here. They can also be pretty lightheaded, have some heart palpitations, have a little bit of difficulty breathing, hypotension because you've got decreased stroke volume and decreased cardiac output. And they can be lightheaded, same thing. We're not perfusing the brain very well. Interventions, thrombolytics. If they have atrial fibrillation, they will be on thrombolytics. They want to make sure that they break up any clots in that blood so that if they have an effective contraction and they shoot more blood through there, that they're not shooting clots too. And then, especially if it's chronic, if they come in, they've never had AFib before, never had a heart history, having all these heart palpitations, they're sweaty, lightheaded. Sometimes they feel like they're having a heart attack. They don't really know. They come in and they're in AFib. If they haven't been in AFib for very long, then they'll do, more often they'll do a cardioversion. And we'll talk about that in a second. All right, so medications. Amiodarone is an antidysrhythmic that they can give them to help convert this AFib. Now, adenosine and calcium antagonists like diltiazem, only if the ventricular rate is tachy, but it won't convert the AFib. So this is what I mean. You see AFib here. On this 6-second strip, 7, 8, 9, 10, 11, so 110, right? That is a tachycardic rate. So if I give medications to slow that tachycardic rate, then we might be able to slow it to 90 or 100. Just slow it down just a little bit. But it will not convert the AFib. It will just slow the ventricular rate. Then, when you give the amiodarone, then it will convert the AFib. Okay, so sometimes they need to treat both. Sometimes they'll treat the AFib and it resolves because the heart's not working so hard and going so crazy, then it resolves the tachycardia. But if it doesn't, then they will go ahead and give like diltiazem or adenosine to slow it down. And then they'll give them thrombolytics. Other treatments, synchronized cardioversion, so it's on the R wave. So what happens there, when you go to shock somebody and they have the defibrillator, and they turn it on and it's ramping up, right, at what you set it at, the joules that you set it at. Then when they go to shock them, they don't have an organized rhythm. They have a heart rate that is just all over the place. Or it's just fibrillating, like ventricular fibrillation, where the whole heart is just fibrillating. And it's not, doesn't have any effective contractions. So then they can shock them wherever, however, doesn't matter. Slap those pads on, charge it up, shock them. Now, if they have an organized rhythm, like in AFib, we've got the disorganized atria, but we have a very organized rhythm for our ventricles. You can't just go and slap them with a bunch of electricity, or you can end up putting them in more of a lethal dysrhythmia. So you need to hit that electrical shock right on the top of the artery. So that's a little hard to do for you and I, right? You're watching, you know, no. Not sure when to push that button. And so the defibrillator does it for you. And you turn it on, turn the button to sync, and then you will see these little dots that appear above the airways. So no matter when you push discharge with that, to send all the electricity to the patient, as soon as you hit that button, it won't deliver the charge until it's right on top of an airway. And so that's why it's synchronized. Cardioversion. So it cardioverts or changes the rhythm, and it'll do it right on top of the airway. It's pretty cool. They can do a catheter ablation. Do you know somebody? Is that why you asked?
I'm sure that it's a no.
Okay. Yeah, so they can go in. Do you want to describe it? Oh, okay. So they can go in and basically cauterize areas in the atrium and scar them so that you don't have all of this, all these impulses. And you have a little bit more organization and less of a chance of having all of these PLAs and all of this fibrillatory activity. And it's really quite effective. A lot of patients have had it done, and some of them more than once. And we would have patients come into the ER and they'd be like, yeah, I had my ablation done 5 years ago, having any trouble, but today I'm having trouble. I can feel the heart palpitations, I feel really lightheaded. They come in, sure they're in AFib, they cardiovert them, sent on their way. And then they don't have any trouble again for a long time. Every once in a while they'll flush you kick back into, I wish my sneezes were that delicate. I'd blow my eardrums out if I sneeze like that. Always call your physician if it's new onset. So if you are watching a telemetry strip and you have a patient that doesn't have a heart history or hasn't ever had AFib, make sure that you let your physician know very quickly. Okay.
Does that hurt like crazy?
The cardioversion? Usually you will do conscious sedation. So you'll give them a little bit of propofol or something, and just kind of make it so they're very sleepy and they don't care too much, but not so sleepy that they need to have like an oral airway or anything like that. Usually you can just have a respiratory therapist just hold them, chin thrust, head tilt, chin thrust, and they just kind of hold their airway open, and then you give them a little bit of propofol and shock them. It goes back to normal rhythm. And you stop the propofol and they start to wake up. Very cool. It works very cool. One thing, does anybody know with adenosine something, has anybody ever seen that used? I forgot to tell you this. So with adenosine, where it slows down their heart rate, when they give it to them, it actually, we don't always give them anything that's going to, like propofol, that's going to put them in conscious sedation or anything, but it can actually stop the heart rate for just a second or two and then start doing the normal rhythm. So when it starts again, it feels like this thump, and it is very disconcerting. And so it's something that you need to warn your patients that, you're going to feel like your heart stops, because it will, and then it will start again, and they're always like, what if it doesn't? We're like, that's why you're hooked to 1 million monitors. We have 15 people right here and a defibrillator, because it's going to be, we're here and we're ready if it doesn't. But I have never seen it not start, but it is excruciating watching that couple of seconds with just like this, and then it starts again. Yeah.
You know, this is not, they got their best of the
Oh my goodness.
Yeah.
I've never seen it.
They were in the cath lab and like, we had signed forms and everything, and the cardiologist was like, I haven't seen it happen, and he was like, okay, and he signed forms and she gave the dose, and we were waiting, and like, we watched like the 2 that missed, and we were like, we should be good here, and it didn't come back, and she said, we'll give them 3 more, and they didn't come back, and so we called the whole dose back to the
Oh, that's so fun.
But she was like, that's the first time she was
Yeah.
the cardiologist was sure because that was the first time she'd ever seen it not come up.
Yeah, I have worked with ER physicians that said there were a couple of times that they had seen it not come back, and they just shocked them once, and then it was there. But I haven't ever seen it not come back. But boy, you sweat bullets. It's a long couple seconds. So just know that you need to warn your patients when you give them an anesthesia that they will feel their heart stop, and that it's a big bump when it starts again. Oh, that's it. We did that one. All right, atrial flutter. It originates in the atrium. So that's going to tell us that our QRS is going to be narrow, right? Because it's above the ventricles. So it's not this wide, bizarre ventricular rhythm. Our rate is variable. So the atrial rate is a little slower than it would be with AFib, but still so fast it's very difficult to count. Your ventricular rate is normal, or it can be tachycardic, so same as with AFib, but the rhythm is mostly regular. And when I say that, it's like the 95% of the time. I have seen a case or two where it was irregular, but it was very obvious that it was atrial flutter. And when you look at the slide, it'll be a little bit easier to tell. We can go back to AFib and back to A-flutter so you can kind of see the difference. Often 2-to-1, 3-to-1, or 4-to-1 conduction. I'm not going to ask you that on the test, but you will see a pattern. And there's like 3 flutter waves and QRS, and 3 flutter waves and QRS. And you will start to see that pattern, and then that's a good indicator that it's atrial flutter as opposed to AFib, where there's no pattern. Your P waves are uniform, but they look kind of sawtooth. And what we mean by that is if you take a saw and you took it on its side, and you can see kind of the teeth to it, it looks kind of sawtooth like that. The PR interval is not applicable because you have many P waves to your QRSs. QRS complex is still narrow, and your ST segment and T wave don't have issues, but it's usually buried in the flutter waves. And you will notice that even more now because the flutter waves are a little more, they look a little bit more like T waves, as opposed to the others that are just fibrillatory. So causes can be heart disease, open heart surgery. So some of your little kids that have the heart surgeries that have the heart anomalies, then they can end up having a little bit of atrial flutter as they're healing or as they have teeth or wires. And then once those are removed and the heart's not so stressed from having surgery, that they can atrial flutter will resolve. Okay. Okay. Oh, we're about ready for a break. I'll do the strip with it, and then we'll take a break. You guys will have to tell me because there's a glare on that clock, and I don't have a watch on today. So you can just be like, it's time for it. Stress, tobacco. So if somebody is a chain smoker and they just smoke a lot, like a couple packs a day, sometimes they can end up letting themselves into atrial flutter. Heart valve conditions, lung disease, and diet coke. But I don't know on the other side. Fen-phen's always my go-to, but I don't know. Okay. I don't know. Maybe I should go look and see. But I just know that when they come in and they're like, oh yeah, well I thought 1 was good, so 2 would be better. And now I'll make atrial flutter. All right. So what's your rate? 70. Perfect. Okay, then what's your rhythm? Yeah, any kind of regular. Regular. Okay, so it's regular. What about your P waves? Do you have them? Do you have 1 before every QRS or many? Many. So we know it's not a sinus rhythm, right? They're not coming from, bless you, from your SA note, but they're nice and pretty and round, 1 before every QRS. So it's got to be, so we've got lots of P waves. So we know that it's going to be atrial. And what else tells us it's atrial? Narrow QRS. Yes.
So, now you're talking about how there's like the P waves overlap the T waves and you're not sure if that's what's going on. How do you know this? This is if there's no
Right. No differentiation. That's what you don't know. You don't know if it's happening in between here and you're just not seeing it because it's smaller, it's going so fast. Sometimes they are landing, sometimes thankfully they're just missing. But you won't be able to identify a T-wave very well in a rhythm that's like this. Just know that the ventricles are repolarizing somewhere in there because you keep having QRSs depolarizing.
You know, you just watch your patient take the rest.
Yeah, and just watch patients. Watch them pretty close. Yes. So you have a narrow QRS. Now what about your ST segment? It kind of hangs out there, doesn't it? So ST depression? Sure. We can agree on that. See how it just kind of makes a little scoop and it doesn't come right back to baseline. Right back to that isoeccentric line. Isoelectric line? I said eccentric the first time, didn't I? Isoeccentric line. And then you've got your T waves possibly right here, but lots of P waves too. You can kind of see a pattern, right? It's either T wave and a 3-to-1 conduction, or it's just 4-to-1. But there's a pattern nonetheless. And if you were to look at it this way, it kind of looks like a sawtooth. And they're much more fluttery. If you think about like the fibrillatory waves, that's just like this shaky little baseline. And then they're more fluttery, like, I don't know, like a butterfly or something. They're just more of a fluttery wave. So that's atrial flutter. And I think in our practice slides, I do have two next to each other. You can see AFib and influtter right next to each other. They can be asymptomatic, or they can have heart palpitations, weakness, dizziness. So with the weakness and the dizziness, that's because they're going to have cardiac output that's not as good as it should be because we've got lots of these little P waves and it's not getting through to the ventricles so that we have a QRS for every P. So we're going to have decreased cardiac output like we would with atrial fibrillation. They can pass out, have a syncopal episode, shortness of breath, and chest pressure. So they don't necessarily call it chest pain, and it doesn't usually radiate down their shoulder, up in their jaw, anything like that. They will just say it feels really heavy, but not like the elephant on my chest kind of heaviness that sometimes they say with a heart attack. They will just say it just feels like there's some pressure on the chest. Interventions, they can do cardioversion, so that's the synchronized on the R-wave cardioversion, medications, and vagal stimulation. So they will have them bear down like they're having a bowel movement, or some people will just assume gag themselves. They're like, if you're vomiting, then sometimes you can slow down your heart rate, and then they're like, oh, here, the ones will just gag themselves. And that sometimes can work to slow it down. We also, there's a maneuver called it elicits a diver's reflex, and it's ice to the face. So you literally take a bucket of ice and just put their face in it. And it causes what they call a diver's reflex, and it can slow their heart rate. So divers that are going into very cold water have to be really careful because they can wiggle down their heart rates. All right. Oh, last one for atrial flutter, and then we'll take a break. So medications like digoxin, that's one that probably we'll talk about. Can slow down their heart rate. Beta blockers and adenosine or diltiazem. If you have a fast ventricular rate, like with atrial fibrillation, then it can slow those QRSs. Okay, so it can slow them down a little bit, but it won't convert the atrial flutter. It won't make that problem go away. That's where you have your digoxin and your beta blockers. Some of your other medications that can help with that rhythm. And then sometimes they'll do the amiodarone antidysphomic like they do with atrial fibrillation. Other treatments, synchronized cardioversion and vagal stimulation. You can have them gag or cough. You can have them cough really hard or bear down like they're having a bowel movement, and that can slow their heart rate. Okay, so we'll start back with premature beats when we come back. So come back in 10 minutes, like 10 after, 12 after, and we'll keep going. What you say? You need to get a drink?
Yeah.
Borrow food.
Yeah, I was gonna say. I'm gonna go tie one on before I come back for ECGs.
Yeah, absolutely. Yeah. Prep yourself for this kind of material.
I had that too, and I was like in the middle of class. I feel like half the class was like this on my embarrassing moments. I was like there. My embarrassing, like 90% of it. But I like I literally thought funny that they shut the clock. I was wondering like what the sign was. Oh yeah, okay, where the parking is. And so the other day when I went to that city, so yeah, I think I would remember when I mean, yeah, like I'll ask if I'm happy with it. Oh yeah. But also too, yeah, like I'm just so bad. And I'm like, yeah, and I don't want to watch. When you get that done, you can't get anxious, and then that like exacerbates it, and then you with like the COVID scare, people don't know how she can breathe. And then they just like make it worse. You know what I mean? And then they also don't know like they should stay prone, like open your lungs out. What are you? The usual. The usual. Sorry. I haven't, yes, I haven't done a lunch. I don't know how long. And I was like, I did GAF about that. Like, I would have been part of the school. Like, I don't know, I remember to start the 12 hours if you want, but like, what is more about this does not want to start with 12 hours. 36 hours. I'm
Okay. All right, you guys, let's get going. Okay, hey, here we go. So, let me preface premature beats with, they seem a little crazy at first, but we'll make sure they make sense before we go on, okay? You have a couple of different kinds. You have premature beats that come from the atria, and you have premature beats that come from the ventricles. So they're the most common dysrhythmia, but it's not its own rhythm. And so what I mean by that is you can have a normal sinus rhythm, but have a premature beat kind of dumped right in the middle of it. And then keep going with normal sinus rhythm, and then all of a sudden have a premature beat. So it's not a rhythm by itself. It's something that is kind of superimposed on whatever rhythm is happening. It can arise from any automatic tissue in the heart, so the SA node and atria. Those are your PACs, premature atrial contractions. And from the bundle of His and Purkinje fibers, so down around ventricles, or PVC, premature ventricular contraction. All right, clear back to the beginning, we talked about ectopic beats, right? So those are any beat that occurs outside the SA node, and sometimes they'll say they're having ectopy, or they have ectopic beats. That is a really bad thing up there, and I think that's pretty funny. Yep. You look at that and go, oh, that's pretty ugly. All right, so premature beats, there are a lot of causes. Almost anything that is out of the ordinary for someone, if they're coming out of surgery, if they have drug and alcohol use, if they have hypoxia, if they have coronary artery disease, would they have congestive heart failure if they are very fluid overloaded? Then sometimes they will have ectopic beats or these premature beats. Patients that have, if they have infections like sepsis, they can come in and they end up having a lot of PVCs, that's premature ventricular contractions. Sometimes with PACs, you'll see them with exercise, and sometimes they'll feel a little fluttery in their chest, but PACs aren't ones that are necessarily as big, bad, and ugly as PVCs. PVCs can start to put them, if there's too many of them, into a lethal dysrhythmia. A sudden increase in blood pressure, and then digoxin toxicity. So sometimes they're on digoxin for a long period of time, and maybe the dose is too high, and now it has built up, and it's toxic. Then it can end up causing some premature beats. Okay, so premature atrial contractions first. They originate in the atria, and the rate, it's that of the underlying rhythm. So if you have a rhythm that's normal sinus, that's 60 to 100, that's going to be your rate. If you have a rhythm that is very regular, and it's just going along very regularly, then that is the rhythm. But then you will have some premature or early beats. Okay, so I'll show you when we look how to identify whether it's part of the rhythm or whether it's a premature beat. Then your P waves are normal in your underlying rhythm. And that's going to be a key in identifying what is normal rhythm and what is early beats. They're different, a different morphology, so they come from a different place. So remember our wandering neutral pacemaker? Our P waves kind of all look a little bit different. Now you will have P waves that there's one before every QRS that all look exactly the same. And then all of a sudden you have this little beat that comes early and it has a different P wave to it. So it looks a little bit different than all of the others that are in that rhythm. The PR interval is the 0.12 to 0.2 on the underlying rhythm. So it's unchanged on your underlying rhythm. So that normal sinus that's just going along, that PR is unchanged. But then all of a sudden you have an early beat that has a different P wave, and it will have a different PR interval. It might be much smaller, might be a little bit wider, but you'll be able to see the difference. Your QRS will still be narrow because it's atrial, right? It's coming from above the ventricles. And your ST cycle and your T wave won't have changes, and this will go the direction of the R wave. So the T wave will go the direction of the R wave, same as all of the rhythms that we've had so far. Okay, so first, what's your rate? 80. Okay, so then for your rhythm, this is what I want you to do. It looks initially very irregular, doesn't it? Just at a quick glance. Look at your P waves. Those look very similar, right? That little PQRST looks the same as this PQRST. Looks the same as this PQRS. That T is starting to lean into one that looks higher and further out, right? So let's keep an eye on that. Then when we look back to here, this little PQRST, those look very similar, but then all of a sudden we have one that looks a little wonky again here, right? Different from those. So if you look at the ones that all look the same, that is going to be your underlying rhythm. That is what's going on with the heart. So that's where you'll count your regularity. So we'll get here, it'll be regular, and then all of a sudden what happens? We have an early beat, correct? Something happens early before what we would have had. Then we look at our ones that are the same as what we had before, and we're back to that same regularity, but then what happens again? We have another early beat, and that looks different than all of these that we were counting in our regular rhythm. So you would still say that it is a regular rhythm, but there are early beats that are happening. And now we need to identify what those early beats are. So we look here to this first early beat. Do we have a P wave? Yes. So we already know that it's going to be above the ventricles, right? So it comes early, so it's premature. It has a P wave and a narrow QRS. That's going to say that it's atrial because it's a ventricular one. It's not going to have a P wave, and it'll have a wide QRS. So it's a premature atrial contraction. When we go back to our regular rhythm here, and then all of a sudden we have that early beat again, do we have a P wave and a narrow QRS? So if you look at your regularity here and here, all of these look the same. So if you put your fingers there, it's going to happen early. And then if you go like right from right there, see how it kind of goes back? The regularity, and then it happens early again. If you have a question on whether it's early, just look at your P waves. Almost every time, I wouldn't say 100% because there are times when it's not really different looking, but almost every single time, that P wave is going to look different. It's going to look different than all of the underlying rhythms. Okay? So see how it goes back? Now this one here is looking a little bit more like that. And so you might have an issue here too. If you look at your irregularity, my hand's not right here and here. And then if you were to look here again, it really is kind of an early beat, and it's looking similar to this, which is looking similar to this. So if you are looking at early beats, then make sure that you look and see if there's a P wave and narrow QRS. So when we look at our PVCs, you will see that there isn't a P wave and there isn't a narrow QRS. The third thing that you can look at is your T wave goes the same direction as your R. In a ventricular beat, it won't. So there's three things: P wave, narrow QRS, T the same direction as the R. That will tell you it's atrial. Okay. So, or these here that all look the same are sinus beats, right? Because they're all coming from the same note. They're all exactly the same. So if you were to see this on the test, then you would call it, so we're in 80, right? So we're 60 to 100. So we're not too fast, not too slow. You have normal sinus beats. These look the same over here. So you would call it a normal sinus rhythm with premature atrial contractions. Okay?
We're not actually about to the contraction. With it,
1, 2, 3, 4, 5.
yes.
This one here.
Yeah. It's kind of pointing more the other way, is it not?
So your T waves, we just look mostly that they're there.
Okay.
They aren't necessarily going to play into whether it's a premature atrial contraction or not. We just like to see that they're there. Your P waves are going to be your really good indicator that it's coming from a different place. Yeah. Your PACs, signs and symptoms, these are your clinical manifestations. Heart palpitations, it'll feel a little bit like they're skipping or racing in their chest. They'll have some dizziness, excuse me, syncope. They'll be kind of diaphoretic. So when they come in, they'll say, I feel like kind of my heart is skipping a beat, or like it's kind of jumping in there, and I don't really know, but I don't feel very good. I feel kind of dizzy or weak, and they'll be a little bit sweaty, and so all of that will kind of present together. The interventions, they rarely require treatment if they're asymptomatic. Sometimes they'll be given meds that are antidysrhythmics that can help kind of knock out those PACs. But most of the time, if you cure the underlying problem that's causing your PACs, they'll go away. Okay, so if you have, let's see, where's my causes? Hang on with me. Where are my causes? Where'd they go? There we go. Fluid overload. You pull some of the fluid off. Give them some Lasix or something if they have congestive heart failure. You can knock out some of those PACs. If you resolve the infection, give them some antibiotics, give them some fluid, support your blood pressure, you will start to see the PACs go away. So anytime with premature beats, if you can help cure or push in the right direction the underlying problem that's causing it, you will see the premature beats go away. Sorry. Figure out which direction I'm going here. All right, so meds, beta blockers, but they're not often needed unless they're symptomatic. So if they're really struggling and having a hard time with this and uncomfortable because they're feeling like they're skipping beats, they're feeling kind of dizzy and diaphoretic, then they can give them some beta blockers, and sometimes that will help regulate that heart rate and take out some of the PACs. I don't see that very often. with cases, there have been a couple cases. I think that what could have been done to help cure the cause wasn't attacked as well as it could have been. Instead, they just threw another med at it. But most of the time I've seen them just fix the fluid overload or fix the hypertension or things like that that are contributing. So other treatments avoid the overuse of stimulants, exercise regularly, and then often other treatments are not necessary.
I'm assuming we're gonna be able to identify what it is, what causes it, and how to fix it.
Yeah, so you will have some questions about your polarization, depolarization, repolarization, so your electrophysiology. You will have 10 strips, and you will have a couple of questions that say something like, clinical manifestations of this particular heart rate would be.
Oh.
Or so, that they might be diaphoretic, they might complain of chest pain, or they might, or you have, so we usually don't ask you to diagnose because nurses don't do that. So I wouldn't give you symptomology and then say, what do they have? Usually I would say they would come in, they've been diagnosed with premature ventricular contractions. And they have a heart history, they have a history of hypertension or a history of congestive heart failure or something like that. What would be an intervention? And then give you some of the interventions. Does that make sense?
Yeah.
So-
How we're gonna be talking about this information, we need to know like all the meds that we need to know.
No, so no meds for me.
I know that for me.
Just knowing that they would have meds would be plenty. I'm giving you the names so that you hear them twice. You hear them from Corey, you hear them from me, make those connections. Okay. But yeah, we'll do some practice strips, and then we can talk about some of the practice kinds of questions. All right, PVC. So these are your premature ventricular contractions. So it originates in the ventricles. Now, that being said, only the PVC originates in the ventricles. So you will have an underlying rhythm for 45 minutes. Oh, yeah.
Did you guys get one message to your cameras?
Yeah.
Sure did.
Okay, all right.
We have a couple of questions.
Okay, yes.
So you said that you're not gonna record it,
But it's live, yeah.
so I haven't.
Yeah, we can have the document. You know what I'm saying? So that's what we're gonna be going over, is the review document. So
Are you doing it on Blue Button?
Yeah.
Oh, yeah, so it's
we
easy
can
to record.
record it, yeah. So, yeah, right. And so that's kind of, we're getting some clarification, because now that we're all back in, even though there's some that are still not really confident, it's fine. But we expect you to log in, you know what I'm saying? And so we're having some clarification whether the live lectures are gonna be recorded.
Oh, they told me to do it.
Yeah, so we're having some discussion about that.
Oh, I think as long as we have students that are not comfortable coming in,
Yeah,
or
well,
they're symptomatic.
No, that's fine, yeah, no, they log on. You're supposed to do, like I said, so they log on the same times that you guys are in here.
Oh, I see what you're saying. They're watching now.
Yeah, they're watching now. Yeah. I'll record it for today. This is just an extra class, an extra little olive branch, okay, for all of you. For pharmacology, okay? And did the review document look okay? Okay, so you can print that out, you can bring it. Like I said, it's not a review on lecture, it's Q&A. Does that make sense? Okay. Questions? Good?
Did that answer yours too?
Yeah.
Okay. Well, that is an egregious offense. Because onions.
So we just right after. Yeah, you have to do that at 1:20. Yeah, so 1:30. Gives you 10 minutes to, that'd be great. And then we'll do 1:30.
Okay,
Alright, so,
just in here?
yeah, so you're not going to stuff. And then I have to do class officer for PN1, so I'm out of here at 2:10. Okay? You good? Yay. This is where you shake your head yes.
Yes, ma'am.
That you heard me, and we're good. Okay. All right.
Thank
Go
you.
on. Okay. Love you.
Thanks, Debbie. Okay. We will. I will record. I don't exactly understand.
I agree.
So,
I get why she's saying not to record. She's saying that.
We want you all to be in class. I get that.
Yeah, she doesn't want people being like, oh, they're watching later.
Yeah.
like Chantel, if
Yeah.
you want, like, I've got the numbers on, cause like we upload them on the YouTube page, and I can show you, like, I mean, we use a crap out of
We
it.
do. They're viewed so many.
Like, we have so many views that, so like, we can go back and like look at different portions of the lecture, and we were noticing last semester. Yeah.
No.
Like they're being reviewed, and like everybody's grades last semester like shot up once we started doing that.
Uh-huh.
It's a fantastic study way. Like,
Yeah.
Especially if you're
So
driving,
much.
you can listen to it in your car while you're driving.
Well, and when I don't know, because when you guys were in class before all this happened, we always suggested that you guys bring a little recorder and record the lecture.
Yeah.
And we had students that were struggling that started to do that, and then they'd go for a run or something and they'd listen to part of the lecture. And it started to help them, just pieces that they didn't quite understand or something. So I don't understand why we would suggest that you record it before and then not record it now. Yeah. Yeah. Well, I will definitely be the advocate for that because I don't think we shouldn't, especially where we were suggesting before that you bring your own recording device and record it.
I can see
So
what
you can
she's
listen to
saying.
it later.
Yeah, I get
I
that.
agree, like, with
We
what
want
she's
you to be
saying,
in
like,
class.
if we're coming to class, like, the other people should have to be like, all right, I'm gonna turn it on and just roll over and go back to bed. So I think, like,
Right.
if I wanted to do that, I would be doing that. Like,
Yeah.
so, like, right, no,
Yeah.
that, I'm just.
So
talking about, like,
I can
like,
see the
I can
discussion.
understand,
I guess,
like,
but-
where the thought process is
Mhm.
coming from for sure.
I do too. I do too.
Wait,
Okay.
recording.
Yes. All right. Here we go. Back to PVCs because it's way more interesting. All right. It's the same as PACs. It's not its own rhythm. So you can have a very regular sinus rhythm, beautiful P waves, QRST, it's looking fabulous. And then all of a sudden have this wonky PVC in there. That is ventricular, it will not have a P wave. It looks very bizarre, and the T goes the opposite way. You'll be able to identify PVCs are easier to identify than PACs. You really have to be watching a telemetry strip on somebody to identify some PVCs. You can see from like you on the monitor, whoa, that's a PVC, which is good because they are more dangerous. So you won't have P waves present on the PVC. So it still will be present on your underlying rhythm. Okay, that beautiful normal sinus rhythm will have all your P, QRS, and D waves. But the PVC won't because it's ventricular. It's coming from the ventricles, so the atria didn't equalize. The PR interval, not applicable on the PVC because there is no P wave. QRS will be wide and bizarre on the PVC beats. You see how there's like this theme that you can have a very regular rhythm and then have this crazy beat that doesn't have any of these things. On your ST segment, it's kind of slurred into the QRS, so you can't see it. And the T wave will go the opposite direction of the R. So causes. So think about things that would cause your heart to have not necessarily a whole messed up rhythm, but just a few beats here and there where it's struggling and it's being taxed. So ischemia of heart tissue. So if someone's had an MRI, or someone's had surgery, a lymph node, anything that has caused a decrease in oxygenation to the heart muscle can cause PVCs. CHF, electrolyte imbalances, particularly hypokalemia. So if you wondered about your PVCs, it's the same as those ET waves. If you are looking at that and you're like, oh, yeah, PVC, oh, there's another one. A really good place to start in identifying that, especially if someone hasn't had a heart history, is to look at your electrolytes. Okay, so PVCs and T waves will give you good indicators about electrolyte imbalances. Pacemaker wires, once those are removed, then they don't necessarily have PVCs in them. You can resolve that by removing your pacemaker wires. And then anesthesia, if they've had surgery and they're kind of waking up and we're doing frequent vital signs on them, and you're noticing some PVCs, as they wake up, if the anesthesia gets further and further out of their system, then you will start to notice a resolution, and they will have fewer and fewer PVCs, if the anesthesia is the cause.
Name version, I'm sorry. So are PVCs more serious than PACs, and do they have the same clinical indications?
PVCs are more serious, yes. You don't want the PACs in the symptomology, they'll feel uncomfortable. PVCs, they'll feel more uncomfortable, but they have a higher likelihood of becoming lethal, especially if they get closer. So you have one here, and then you have one here, but then all of a sudden you're having one every fourth beat, and then every third beat, and then every second beat, and they're not perfusing beats. And we'll talk about that more in a minute. They don't perfuse. So the more of them you have, the worse the perfusion and the worse condition that they're in. Yeah.
So, is this system like, ACL, like, taken out, basically, like, it's not going to stop the people who are the next system, like, how we talked about more than, like, you guys just talked about, like, preventive after
Yeah. So yes, so you can have what they call sick sinus syndrome. So the SA node isn't firing well, so then the ventricles are taking over. But what you will see, we'll show you some different ones, and when they occur looking differently in the same rhythm strip, then usually that's an irritable or angry spot in the ventricles that's just firing.
So it's not like, because the ACL didn't want to fire it, because the ventricle.
Yes, yeah. So most of the time, you've got this nice underlying rhythm, and then it's just firing off these ventricular beats, and it's not waiting necessarily for a normal P2RST. It's just got this early beat that it's interjecting in there. Sometimes if you have a heart history and maybe it's history of heart blocks, then you will drop P waves and you will have other issues, and so then the ventricles will pick up. Sometimes we would just have straight ventricular beats, and they don't fuse well. So it's kind of thumping in their chest because it's a big beat. So you're beating along, and all of a sudden you have kind of this thump where it's an extra ventricular beat. It depends on how many they're having. So if they are having one every now and then, sometimes they won't be symptomatic. But if they're having them pretty regularly, they'll feel very uncomfortable, have some chest pressure, be kind of sweaty, feel like they've got heart palpitations going on. But if you fix what's causing it, then you will generally fix what's happening with the PVCs. Does that answer your question?
Yeah.
Okay, yeah, good question. Okay, and then acid-base imbalances. So if they have respiratory acidosis and they're trying to compensate metabolically, and we help them get there, then you can resolve all of those PVCs. Yeah.
Question. So I know how they like would show up like on the ECG, but let's just I have a question regarding like if they have like the ischemia of the heart, is there like a certain period of time where like the heart just goes back to normal and you can't see like the visualization? in the EKG, so like a certain time that we have to like take an EKG of their heart before it notice.
Oh, I see what you're saying. Yes and no. So if you have these problems, like an acid base imbalance or an electrolyte imbalance, and you got an ECG then, when you see those labs and you're like, oh, we've got quite a shift in our pH or something like that for acid base imbalance, let's get an ECG and just see what their heart's doing. But once we resolve that acid base imbalance, then you may not see those PVCs anymore. But if you were to see them on a telemetry strip, and that's often where people see them, like with anesthesia or something, we've got them hooked up to their telemetry strip because they're waking up, we're doing frequent vital signs, or we have them hooked up to that monitor. That's often where people will notice it, and that's when you want to go ahead and get an ECG, because you can miss your window if it's anesthesia that's causing it. The more the anesthesia works its way out of their system, the fewer PVCs you'll see. And so they're a really watch and wait kind of thing. So if you're watching your patient, you notice a few, go check on your patient. Then when you're assessing your patient, watch the monitor, watch what they're doing, see the symptomology that's going on. If they're talking to you and they're fine and they're having a couple of PVCs here and there, document the heck out of that. And then if you are starting to see more, then go talk to your patient and see the symptomology. See how it correlates. If they're starting to go, wow, I don't feel very good. I feel like kind of dizzy or lightheaded, or I feel kind of clammy, or you feel their hands and they're starting to feel kind of cool because they're not perfusing beats. So you might count your heart rate to be 100, but if you have 4 PVCs in there, then they're only perfusing at 60 beats. So even though you count it to be 100, they only perfuse the beats that are your good peak force. So I'll show you that here. But yes, you can. If it starts to resolve, you can kind of miss that window. But most of the time, you'll be able to catch it. Yeah, good question. Yeah.
So if a patient, like, for example, with anesthesia, if they get a PVC, are they more likely, like, anytime that they go under anesthesia, sometimes their PVCs are done? It's kind of like the same, if it's being out of the system, you're not going to notice those PVCs, and then they're gone. That's not a condition for them.
Right. So if they didn't have an underlying heart issue, and maybe they had an abdominal surgery, and then now they're waking up and you're noticing some PVCs, it is very likely that those will resolve and they won't have a further issue. Is it likely if they have anesthesia again that they will be there again? Yes. If they were there with anesthesia before, they likely will be again. Yeah. Yeah.
Is it with these, like, sometimes
Yeah, especially if they're having many. And they send them home with a Holter monitor that hooks up, and it's kind of a continuous ECG, and it records, and it actually can be sent to a central database. It's kind of cool. That can record any, because sometimes somebody's complaining of these thumping heartbeats and not feeling very good and dizzy and everything, and then you get into the cardiologist's office and they're fine. They're like, no, really, I really feel really crappy most of the time. And they do an ECG and it's fine. And then they come into the ER a couple days later and they've been feeling really crummy and they get in there and it's fine. Or they have one PVC. And they're like, no, really, I'm feeling really crummy. Then they can set them up with this continuous ECG monitoring for a couple of days at home to see if they can catch that over the weather. That makes sense? Was that your question? Okay. So a PVC is when the ventricles assume the pacing responsibility, and it bypasses normal conduction and results in an abnormally shaped or longer QRS. So what's your rate? Count all of your R waves. What's your rate? 60. Perfect. Okay. What's your rhythm? That happened early, right? Okay. And then that's not quite right. So we go back to here and we're like, okay, so do I have, is this here looking like this here? Yeah. So we have P waves, very similar. Do we have a narrow or wide QRS? Narrow in our underlying rhythm, right? We'll talk about that craziness in just a second. ST segment, looking okay. Kind of gets kind of slurred in here, but we've got it here and there, so it looks all right. And our T waves are looking good here and here, and here and here. So we know that that little package deal, your PQRST and PQRST, all these that look alike, one of these things is not like the others. It's very different. But our underlying rhythm is a sinus rhythm. It's in the 60 to 100 range, right? So we're good there. But then we have this early beat. So it's premature. So there's our P. Now, do we have a P wave? Bless you. No P wave. And then is our QRS wide or narrow? Wide. It's wide. And then where's our R and our T? They're going opposite directions. Yes, like this. So this here is a ventricular beat. It doesn't have a P wave, so your atria did not depolarize on this beat. The beat's gonna drop. Yeah, there you go. And then you have, it's wider, and the T and the R going different direction. So you would call this, what would you call this rhythm? Normal sinus with a PVC. Because we've got a normal sinus rhythm going along here. It's in our 60 to 100. All of the rhythm pieces that look the same are very regular. And so it's a normal sinus rhythm with a PVC.
As long as you have like two or more pieces similar, you can call it a sinus rhythm with what we're calling it.
Yeah, so if you can see a pattern of like this regular package deal that looks very nice and it matches other things, that's where your regularity is going to lie.
So maybe like every few beats are normal, and then like one year one, and two regular beats, and then one not normal.
That is exactly where we're going with this. That is coming right up. So hold that thought. So your PVCs can be asymptomatic if they're only having a couple here or there. I've had patients where I'm like, oh wow, they're having some premature beats. You don't need to say PVCs unless there's someone who might understand that, but you say it looks like you're having some early little beats in between your regular rhythm. Do you feel anything, like a jumping sensation, or do you feel dizzy or short of breath or anything? And I've had them go, no, where are you seeing that? And they're kind of intrigued by the monitor. You can kind of show them, see, there was one. Did you feel any difference? And I've had them say, no, I'm just fine. And then I've had them be very symptomatic. The more PVCs they have, the more symptomatic they will be. A fluttery feeling, some weakness and dizziness, and it can progress to ventricular fibrillation, so that's where you have to be careful and watch them closely. All right, so interventions, none if they're infrequent and they're asymptomatic. Give them oxygen. This is the craziest thing. Even if they don't need oxygen, and their sats are fine, and their respiratory rate is fine, breath sounds are clear, slap a couple liters on them. Liter or two, never hurt anybody. And then, but don't like giving 3 or 4 or 5, especially if they're a COPD. Don't do that. Like a liter or two, okay? And watch those PVCs start to go away, unless you have underlying acid-base imbalances or electrolyte imbalances. But if you can't really identify a cause, or you're waiting to look at those labs, put a couple liters on them. And sometimes you'll just see those PVCs go away, especially if they're waking up in anesthesia. They might be breathing okay, but they're still having a fair amount of PVCs. They're like, I'm just going to put a little bit of oxygen on you, and we're going to help your heart rate a little bit. Will be a way that you can take on that. And then mostly treat the underlying sources or the underlying causes. They no longer routinely use lidocaine. Lidocaine decreases the automaticity of the heart muscle, but it has a lot of side effects. Yeah. Usually more short term. Yeah, usually more short term. Okay, lidocaine depresses the automaticity, but has a lot of other side effects. You always treat bradycardia first. So if you have back here, if we didn't have this here, and we only had 50 beats, these are your only perfusing beats. That isn't perfusing. That isn't having oxygenated blood coming from the atria to the ventricles. The ventricles are just firing off with whatever little bit of blood that's in the heart or that's in the ventricle at the time. And so it doesn't do its job. So we only have 50, but we're only perfusing at 40. That makes sense? So you always count it for your rate, but you will look at your symptomology with your patient for the perfusing beats. Are they perfusing well? They cool and clammy in their exterior. They have some edema and delayed capillary refill time. Are they sweaty and diaphoretic? They're having some heart palpitations. All of that symptomology that's showing that they're not perfusing well. Is that what you were going to start to say?
No, because the other person kind of close them because when it's 60 beats, but that one's not confusing, so you're checking to get
50. Yes. So you would treat based on your rate that you have counted. So if that's why I got rid of that one. So they would be 50. So you would treat if it was bradycardic in your underlying rhythm. And then look at your symptomology with your perfusing beats. So with your treatment, basically it means more so with meds. So you wouldn't wait until they're bradycardic to give them oxygen and to do some of these other interventions, but you would treat for bradycardia until the underlying rhythm has become bradycardic. Okay. Now, if you're having all of these, if you're having a PVC every third beat, it's going to be pretty quick that they're going to have fewer perfusing beats. Does that make sense? Okay, so the lidocaine, and then other treatment, correct your underlying problems. In ACLS, they call them your H's, and so you've got look at their history, look at the pH, like a lot of the different things have the H's in it, and that you would look for your underlying problems to be able to correct to get rid of some of the PVCs. So there are different types of PVCs. You will hear unifocal, uniform, monomorphic. That just means they look alike. We will use unifocal. That's the one that I hear and have used the most in my career. Same with multifocal. But you'll hear some say multiform or polymorphic. It just means they're coming from different places in the heart. So if you have all of them looking exactly like that wonky beat that we saw, then they're all going to be unifocal. They're all coming from the exact same spot in the heart. But then if you have a PVC that all of a sudden looks a little different from the other PVC, now you've got another area of the ventricles that's angry. Is that worse for the patient? Yes. Because now you've got more ventricular tissue that's upset about something, right? And so we need to figure out quickly what's going on and what we can correct. Because now we have more upset heart tissue. It's like, wait a minute, I don't like this and I don't like this, and now you've got different parts of the ventricles that are sick, that are firing off at different times. Okay, so what's your rate? Count all your R waves. 60. That's your rate. What's your perfusion? 1, 2, 3. Yeah. So they're perfusing at 30. So here's a test question. What would that look like? You have a patient who's perfusing at 30 beats per minute. What clinical manifestation do you see? Yes, lethargic, level of consciousness decreased. We're not perfusing. I'm not perfusing here. I'm not perfusing here. What are you going to see? Cyanosis, extended capillary refill time, cool and clammy, right? Okay, what are you going to see kidney-wise? Decreased urine output, yeah, because we're not using those kidneys. Okay, so you can see that's when you think about your perfusion, you think about everything that you perfuse. All right, so we have a rate of 60. To find our underlying rhythm, what little package deal do we need to find? QRST, right? That little package deal that looks the same as other ones. Okay, so can you find PQRST? Okay, so there's one. Does it look very similar to PQRST? Looks like PQRST. Okay, so that is our underlying rhythm. Okay, so I'm just going to go here. Is it regular? Yes, it's very regular. But what happens right early, prematurely, a premature beat, right? And then if we go here for our regularity, we have a premature beat again. And then it would probably come off the page here where we have a premature beat again. So we know it's premature. Now we need to figure out if it's an AC or BC, right? So this is our T wave. Do we have a P wave there? Probably a little bit of artifact. But if you thought that you saw a P wave, what would you look at next?
Oh, it's wide.
It's wide. So if it's wide, is there a P wave there?
No.
So then you would look at your T wave. See how it's going the opposite direction of the R? Those three things tell you it's what kind of beat? Ventricular.
The same direction.
Except that it's on a ventricular. So if you were wondering if it was inverted, look at your underlying rhythm that has beautiful T waves.
Oh, so would an inverted T wave be consistent then?
Uh-huh.
Okay.
Yes. And it would be very consistent, and it wouldn't be just on a PVC.
So ventricular electrical current can be either going up or down.
Yes.
Inverted or regulated.
And when we look at VTAC and VFib, you will see. With VTAC, it's a little difficult to see if it's QRS and T or QRS and T, because it just kind of goes like this.
Your number one identifier is VTAC is wide.
Yeah, no P wave, wide QRS, and T opposite direction. If you only have a T going the opposite direction on a PVC or on a ventricular beat, then it is not ischemia, because you will see these other very nice T waves on your underlying rhythm. Now, if this was P, QRS, T, and then this, then you would know that they've probably had PVCs long enough and enough that they're starting to have some ischemic changes. Does that make sense? So your T wave that you're looking at for ischemia, you would look at a very consistent pattern and not just on your PVC. Okay? All right, so when so these are unifocal because they all look the same, right? All the PVCs look exactly alike. So they are coming from one spot in the ventricles. Okay, multifocal. So ignore the bottom for a minute. This was the clearest slide that I could find that had exactly what I wanted. So count your R waves. What's your rate? $50. So we are what? Too slow. Bradycardia. Yep. Okay, so we already have bradycardia. Now we need to find similar PQRST packages that we know would be our underlying rhythm. Okay, so right here we have a PQRST, and we like the way that one looks, right? Then here, a PQRS. Our T is a little shorter than that, but for all intents and purposes looks very similar, right? And then our PQRST looks very much the same. So we know that those beats are our underlying rhythm. Okay, so here to here, is it regular? Sure. We would have to continue to see more to see if it stays that way. But looking at this 6-second strip, if you look from here to here, do you have a premature beat?
Yep.
Okay. And from here to here, do you have a premature beat?
Yep.
Okay. So let's tackle this one first. So we have a P, Q, R, S, and T, so that looks good. So now we've got this premature beat. Does it have a P wave? No. Is it narrow or wide? And where's the T wave? Going opposite your arm, right? So that tells you it's what kind of beat? Ventricular. And it's early, so it's a PVC. All right, so then we look over here. Is there a P wave? No, you're right, because that's your cue. But if you wondered, what's next? It's wide, and it's going opposite. So that tells you that it is also a PVC. Do they look the same?
No.
No, they are not coming from the same place in the ventricles. So it could be left and right, it can be two spots in the left, it can be, whatever. But it's coming from two different places. So that is why it is multifocal. It has more than one focal point. Okay? So you would call this what? Sinus what? Sinus bradycardia. Sinus bradycardia with? Bam. Multifocal PVC. What? Because this one looks like this, and this one looks like this. They look differently. So different families, different places. They don't come from the same place. But they're just a PVC. But they're coming from multiple focal points or multiple places. Okay, yeah.
So on the second one with the QRS one down and then the T is up, is it supposed to be like an inverted?
It's not inverted. Right. It's not, don't call it inverted. Just call it opposite. You would call this inverted from a normal P, QRST. If that T wave dumped down here, then it would be inverted. But this is a ventricular beat. And on a ventricular beat, they go opposite. So if you're looking at T wave inversion, look for it on your normal underlying rhythm, on all of your sinus beats. And it will be very regular. But you're not seeing it here, here, or here. If you had T wave inversion, you would see it very regularly in those beats. Does that make sense? Does that help? Okay.
So it's almost like you don't
Right. Right. And they don't perfuse well. So if we've only got 50, we're already a little slow, and we're only perfusing how many beats? 30. So they're going to look best beat. They're going to have decreased level of consciousness. They might be diaphoretic, might be cool and clammy in their extremities, have delayed capillary reflex time. Pulses might be kind of weak, but you will feel this. You'll be able to feel the PVC. Okay. What's your rate? Count all your R rates. 80. Yes. It is 80. So now, for our rhythm, we need to find that PQRST deal that looks the same. So that one's kind of off the page, so we'll start here. PQRST. PQRST. Those look very similar, right? So we like those two. And this one really looks very similar from what we can see. So we probably could even include all three. Then that we're not going to count for now. It's very different. But if we go back, it's kind of coming down towards P or ST. And it's looking very similar again, right? So we like those beats and those beats for our underlying rhythm. So that's where we'll count for our rhythm to see if it's regular. So we have an early beat. And then if you pick back up with your regularity, then you go off and there's an early beat again. Okay, do you see how I found the underlying rhythm? Always look for what looks the same and has all those components to it. So it has a P wave, so we know that and all the P waves look the same in that underlying rhythm. So they're likely coming from the SA node. It's a sinus rhythm. Is our QRS narrow or wide? It is narrow. If you're questioning if it's looking a little wide, do you have a P wave? And does your T go the same direction? And that is above the ventricles. That is not wide enough to be a ventricular beat. Right? If it's looking a little wide to you, look at the medications they're on. Some medications can make it be just a little wider. Okay? I promise you, it'll be okay. It'll be okay. All right, so then you've got your early beat here. Does it have a P wave? No, but if you questioned, you're like, oh, no. No, it doesn't. But if you questioned, what would you look at next? It's huge. Yep, so it's a wide QRS. And T is opposite. So that big slurry mess there is what kind of beat? Yes, a PVC. All right, now we come over to our other premature beat. Is there a P wave? No. What's confusing you?
Okay, never mind. It's just that it drops down from.
It does drop a little bit, but your P wave you will see usually a positive deflection. When you get into junctionals and heart blocks and stuff like that, it gets a little wonky. So for our intents and purposes, a positive deflection like this, it's going above your isoelectric line, is going to be a P wave. So there's no P wave. And then what about here? Wide, and then your R and your T. So what kind of beat is that? Also a PVC. Now, do they look the same? Or do they look different? All right, not even close. So you would have your 3, 4, 5, 6, 7, 8. You're in your 60 to 100. And your underlying rhythm is a sinus rhythm. So you would call it normal sinus with multifocal PVCs. Then there's this crazy word quadrigeminy. And it means every fourth beat is a PVC. Now you're starting to see a pattern of PVCs, and that's dangerous. So if you see random PVCs here and there, you definitely need to look at putting them on oxygen, looking at their labs, trying to correct electrolyte and acid-base imbalances, that kind of thing, and looking at what you can do to resolve those PVCs. But then when you start to see a pattern, especially a pattern of multifocal PVCs, now you need to stand up and pay attention, because this patient really has the potential to go down. So quadrigeminy means that it's happening every fourth beat. You will hear it in practice. That makes it 3 parts. I won't ask you 3 parts. I would ask you normal sinus with multifocal PVCs. I won't say and quadrigeminy. Okay. All right, so what's your rate? Ignore the bottom for now. What's your rate? 60. All right. Then to look at our underlying rhythm, we've got a P, QRS, T here. Looks very similar to P, QRS, T here. Also looks similar to here and here, right? So that and that is your underlying rhythm. So I'm going to go here and here from irregularity. Do I have a premature beat? Yes. And then go back to here, and here, and here. Do I have a premature beat again? Okay. So 3, what do we say, 60? So we're still 60 to 100. We still have a sinus rhythm. It's still going to be normal sinus, but we're going to have some of these premature beats. Is there a P wave? What's your QRS like? And your T? Opposite. So what kind of beat is that? PVC. Same here? Are they unifocal or multifocal? Unifocal. Okay, but they're happening every third beat. So it's trigeminy. Getting worse. It went from every fourth, every third. This is a bad deal. Yeah.
When you said earlier, like, when we get full, there's more.
Yes, getting more dangerous. Yep. Especially if there's a pattern to it. Yeah. This is not going the direction we want it to be going. All right. What's your rate? 60. What are you perfusing at? 30. Okay, so think about that perfusion and what that picture looks like if I were to ask you or to give you a heart rate and say they have a heart rate of 60, but they're having PVCs on every other beat. What does their perfusion look like? Okay, so yeah, in the toilet. All right, so now to find our underlying rhythm. T, QRST. Looks very similar to this, right? And this. So that is your underlying rhythm. It's really wide because I really stretch some of these so that it's nice and big for you to be able to see. Yeah. It's mostly, see how bumpy it is and how thick black the line is? You probably have a little bit of artifact. Yeah. Oh, yeah. No, usually it's, especially if you just see how you see a little bit there too. But maybe not quite as well, you still see it a little bit there too. If you have your QRS and then your T, it kind of has just bounced back. And you've got probably a little bit of artifact. Okay, good question. Okay, so then we've got our regularity. We already have a, yes, you're right. What do we have here? An early beat? Stop it. Stop it. Okay, and then here, regular rhythm with another early beat. And then you would probably have the same going on. So now with our early beat, do we have a P wave? Have a little bit of artifact, but if you were questioning whether that was a P wave, what do you look at here? It's wide, and your T wave and your R, opposite. So we know that's what? PVC. Does it look the same as these other premature beats? So is it multifocal or unifocal? Unifocal. So you would call this, so it's 60, right? Of a normal sinus, so it's normal sinus rhythm with unifocal PVCs bigeminy. Bigeminy, you better be doing something quick because that is ugly, especially if it's got a long pattern to it and it's not being broken up with regular beats. Okay. This is the last part of PVC, I promise. They do all kinds of weird things. So don't look at the bottom, it's not a very good view. Usually it's a different view, like one of your V leads. We're looking at this read. Okay, so what's your rate? Okay, so you're in your 60 to 100, right? So we're okay there, not too fast, not too slow. Now we're looking at our P, QRS, T. P, QRS, T. They look very similar, right? We'll skip that mess. They all look very similar. So that's going to be your underlying rhythm. Yeah. Your R waves. R waves. Do we have another beat there, right? If you should have had a beat there, should have had a normal beat, if you take it and go there, it picks right back up and you have another early beat. Does that make sense? And then that one's a little bit early compared to what these were. So if you were going along with your regularity and you were counting here to here to here, that one falls early. That's where a beat should be. Does that make sense? And then if you go here again, whoops, I'm a little bit off. It's a little bit wider, but do you have an early beat again? Mm-hmm. So you have two early beats together. Do they have P waves? What are their QRSs doing? All right, and your R and your T? Opposite. What are they? Both. PVCs. But they're coupled. So they're called a couplet. If you had trigeminy with couplets, would you be concerned? Because you're going along trigeminy and now all of a sudden have some couplets? Mm-hmm. Yeah, because that's more PVCs. Couplets will generally be unifocal. They'll happen together. I have seen them multifocal, but most of the time a couplet will be unifocal. Okay, but you can have multifocal PVCs by Gemini with couplets, and you're in a lot of trouble. Yeah.
So, are these like words?
If there's a pattern. Yeah, if there's a pattern to them. You would count them as two PVCs. So if you went to your physician and said, they would say they're throwing PVCs or they're having PVCs, or they're say they're throwing PVCs. And you would want to tell them, and they're having couplets, just so that they know. Now, if they're having a pattern to the couplets, where it's quadrigeminy, if you would say they're having couplets in quadrigeminy, or they're having quadrigeminy with couplets. No, it's worse. Yeah, because you have more spots in the ventricles that are upset. Yeah. So you would just throw all that terminology out there. They're throwing PVCs, there's couplets, there's trigeminy, there's, and they're multifocal. They'll know that they've got to get in there and get something done. Yeah.
What are the most concerning PVCs?
Most concerning. If there's a pattern, so if there's a pattern to your couplets, or there's a pattern to your quadrigeminy, trigeminy, bigeminy, that's continuing on, so definitely you need to be watching. If you see PVCs, let it alert you to watch. And then see if you start to see that there's a pattern. If there's not, and there's one here and there's one there, and then you start to notice they're a little more frequent. There's not a pattern yet, but they're a little more frequent. Then you have not resolved what is causing them. And so you still need to be digging. You still need to be digging for what is causing them. And so if there's a pattern to your couplets or a pattern to your bigeminy, trigeminy, quadrigeminy, that's where you'd be the most concerned.
So quadrigeminy is not as concerned with bigeminy, but
Correct.
not completely heavy.
Right. Did that answer her question? Okay. We'll see. She's tired. Okay. All right. Could you just see a cardiologist there? No. Okay, so what did we came back at 12 after, didn't we? Mm-hmm. Yeah, we talked about PVCs. Okay, so come back, let's see, 10:35? For a quick break? Right? Okay. Up here, time Time flies. It may not fly for you guys, but all of a sudden I'm like, it's time for a break again? What? What slide are we on? Do we know? 96? Oh, coming down the home stretch. I know, there's 120, I think. There's what? 27. Well, 27, the 127th doesn't count because it's a video. It's the ECG dance. It's pretty funny. There's several of them out there, but I get a kick out of the music in this one in particular. It's like Salt and Pepper and Salt and Pepper from the 80s. And like Who Let the Dogs Out. It's got some funny ones. It's got some funny ones in it.
I'm loving this.
Are you? Do you like cardiac stuff?
Well, I used to be ECG tech, and I didn't know what any of it was.
Yeah.
But I would just be like, it didn't look right.
Yeah.
So I didn't know what anything was. I'm like, hey, Doc, you might want to look at this.
Yeah.
What's wrong with it? It doesn't look right.
That's the case with so many teletechs. They'll come in and they'll be like, all I knew was if it did this, to go get the nurse. If it did this, to go get the nurse or the doctor or whatever. And if there were changes, and that's it. And now it all comes together. And they're like, oh my gosh, yeah. There was a patient this one time that had this, this, and this. And this was happening with their heart rate. And it starts to come together.
Understand why they
So it's like,
Yeah. Yep, for sure.
Oh, that's fun. Oh. You're smart, maybe.
No.
Your study plan was a hell of a lot better than mine. Are you making a study game? No, well, no, I'm not smart. Like,
Sorry, I guess I should have.
Oh my gosh.
God,
What are you
Megan.
doing?
Yeah, come on,
We're
Megan.
all gonna die.
Kylie, I want to go, but I have to be back by Sunday at 6. 6 p.m. Oh, yeah, we'll be back by then. Oh, okay. I just gotta figure out if I, and if I'm the only one going, it would be weird, so. It would be weird. Or you, no, Kim said it. Yeah. Because we're,
I'm just talking about like all in that side of kids or all in that person. And I don't really want to like drive for 5 hours and then like, yeah, I would rather,
Drive,
So-
chill.
yeah.
So wait, no, there's only like 4 different folks.
Yeah, like, I don't like it, but I kind of think I know how
I know.
to.
So I bought one of those acupuncture necks.
I
We got it in the mail yesterday, so I was like, it's doing something because my body's getting all warm.
Yeah.
you need to go to like a massage therapist or like a chiropractor.
Go to a chiropractor first.
I'm so afraid to go to a chiropractor. I'm afraid he's gonna like freaking paralyze me.
Yeah, that's true.
I just like to say, hey, what's your tattoo on your back, Stephanie?
It's a map.
It like goes up my back, so. Oh. It's like, whoa.
Oh, that's cool.
I love it.
It's like half your back. That's so neat.
I want to see what it says though. Lot of them to do must be.
I'm sorry, Mark. I'm like,
You're good.
I love it.
How much they changed, like, this was like 15 years ago, so I'm like, now you look at art and you're like, it can do what on your scale? Like,
Watercolors and glow
yeah,
in the dark.
like, they literally can make something look 3D on their skin.
Yeah, they can.
It's just insane. Yeah.
I think yeah, it was hard yesterday. Sorry, Mark.
Good. How are you?
Good, I love this.
I know, right? I just want
It
to
literally
like,
makes it
I got it for work.
Right?
Yeah, I mean, I was thinking today, I was like,
Oh, yeah, I'll
I was thinking about it today. I was like, remember like 3 months ago where I had to like spray everything down after we touched everything and no one cares.
Yeah, when she said
Oh, hey, I've been over it for months. That was the original. It's not realer. So.
Well, I went out the other one.
That's so comfy.
Oh, that's good.
Yeah, they were so
We need to get like 1 or 2 more good days of farm, and then I'm just gonna pretty chill out the rest of the semester. I'm done. Let's get that average up. Oh, did they use like sprinkler type? That's creative. It's engineering.
They're garbage.
I don't know. Right there. Then like if you're like, okay, that's right. Like it's like okay, that's like oh, but if you want to like I have this and you're like I know it's like I definitely I think that
I'm still giggling. When she said we're going to talk about it, it's probably in our faculty meeting.
and then there's a lot of things it's like here
And I mean, I was just kind of going over the stats of like, we're getting like average 40 minutes.
Wow. That might not hurt.
Yeah, and that, and then it's intimidating, but the big thing was with YouTube, you're able to probably see it like frames that happen on YouTube or kind of go back and forth. And Blue Button allows you to do that too.
Uh-huh.
So it kind of helps out. So like while reading or whatever, I can listen to it on 9.5. So it really helps out. Like, I think like last semester, not slow, but sometimes you can see that you still understand what you're getting lectured. So I just know it's been
That might not be a bad idea to just write a little note and say, hey, you know, I know you're discussing this, and I've noticed all of these views and did the statistics, and I've talked to students who really evaluate. Yeah.
Yeah, I know. I mean, you can't help, but there's probably a couple that are like, oh, you know, kind of you can't help that. I'm not going to assume that that's not happening. But I think for a majority of it, you see
And people that are chiming in that are online.
And then, like, I know, like, at least while we were still completely online, every now and then, it's like I run into something where, like, yeah, I gotta pick my kid up or something like that. And it's nice to be able to kind of go back, like, okay, I can watch this work right here, like,
Well, I think, I don't know, I'm of the thought that you have to listen to it at some point to pass the test.
I think that's.
And you're an adult, and you know when to learn. I think it comes down to professional points. But I think right now where we've got the option to be online and stuff, unless we know that someone consistently is being there, like I noticed when we first pulled up the thing, how many people were online, and we had like 13 people that were there online, and we've got 18 here, so I know I have almost every class. Could they bring it up and then eat their breakfast and do their dishes as they're kind of half listening? Sure. But at some point, they have to listen to the lecture. And so I just don't know that professional points, if we can just be really true to professional points right now, we can do the best that we can. But I don't know. I think I value giving professional points, knowing that you're going to have to listen to it, and giving you the opportunity to take it over having everyone there at that time. But that's my value. Yeah. Yeah.
Anything else you're going to
Right. Their test scores will show it.
I noticed like last semester, some classes started to do stuff. You can see that it's kind of a little bit, and then just we all talk about it. We gotta reset. We gotta be there.
Yeah. Yeah.
Like I think it's YouTube. We're gonna lose it. I'll take it away. I mean, somebody else can do it if they wanted to, but
Yeah.
to take our page, we have our own dedicated page just for us.
Oh, we
And have it, and everybody has that. I'll take it away if I'm noticing that like.
Yeah. Exactly.
I think it's considerable.
That's good. Yeah, I just think I value having you guys be able to reference that more than I value not giving straight across the board professional points. Knowing that at some point you have to be professional enough to listen to your lecture, and be present during it. Because scores are going to show it, you'll end up on a contract or figuring out from the program or.
I think it helps small thing you guys as well. Because it's like you can text you about a question, or let me go back to
Yeah. And it might be there and a little more. Like it might have the example that I need, and the next example was something that I was like, oh, I didn't realize I didn't understand that until I just heard it. Yeah.
Yeah. That's like a lot of us do. Like, a lot of us do we just play the lecture.
Yeah. And in this day and age of, if you work the night shift, you do have quiet spots in the night, and you can put one earphone in or something, while you've got it playing, or you can, whatever. So, yeah. I think that would be great. Okay, you guys, let's get going. There we go. Okay. SVT, supraventricular tachycardia. So where would this one be coming from?
Ventricles.
Supraventricular.
Oh,
Above the ventricles. So it's going to be an atrial rate, right? It just happens to have its own quirky name. So just remember, above the ventricles, supraventricular. Okay? And then tachycardia. It's really nice. You will see these things, and you will hear the doctors use them. That's why I put them here. We will only call it SVT. So you will hear it PAT, paroxysmal atrial tachycardia, and you'll hear paroxysmal SVT, that just means that it started and stopped suddenly. This means you don't see the end of it. So they come in and you hook them up to the ECG and their heart's just going zing. And you're like, whoa. That's what they would then say, oh, they're having P. Okay. Just call it SVT. Okay? They're having SVT. This PSVT means that you saw the start and the stop of it. So the patient calls you in, they're like, oh my gosh, my heart was just racing. And you're looking at the telemetry monitor and they've got this nice sinus rhythm. It might be a little tachycardic, but maybe they're not. And while you're talking to them, all of a sudden you see it go zing, and it just takes off and then it stops again. That would be your PSVT. You'll see what they call a run of SVT. So if they come in and they say, oh my gosh, I was in my patient's room, I was getting vital signs, and I saw a run of SVT. That means they saw like the start and stop of it. Sometimes that will happen, very similar to why PVCs happen. Sometimes there's an underlying cause. Sometimes there is not. And so we'll talk about the difference between tachycardia and SVT. Yes. If the end isn't seen on the ECG, just call it SVT. So for our purposes, we will just call it SVT. So it originates above the ventricles. So technically, it's an atrial rate, right? It's coming from above the ventricles. The rate, so I put 180 to 250, but actually I put the newer one on your paper, didn't I? This is 150 on SVT. Go down to SVT. This is 150? Okay, I forgot to change my slide. So it used to be that 180 was kind of the tipping point where doctors would go, more than tachycardia, we've got SVT. But then the American Heart Association said, what's the other one? American Heart and there's two of them. The American Heart Association said actually 150 is kind of the gold standard. If it's above 150, we need to consider SVT. So 250 isn't necessarily the ceiling. I haven't seen faster than 250, but I've heard people say they've seen faster than 250. This is a ventricular rate here. This is the ventricles going as fast. This isn't those little P waves. Okay, these are ventricles that are going that fast. Your P wave isn't usually visible because of the rate. So how would you know that it's ventricular or not? Right, your QRS, wide or narrow. Not checking the cervix. No. So your PR interval, usually unmeasurable because it's all kind of slurred together, like it's going so fast that you can't do, you usually can't see a P wave and you can't measure a PR interval, and I'll show you when we get to it. You'll be really surprised at how fast it goes. The QRS will be narrow because it's coming from, I can't make a circle, there we go, above the ventricles. That's one thing that I do like about Blue Button. There aren't many things, but that I can draw, that I can circle things. I do like that. All right, the ST segment and the T wave, yes.
So you're saying it's above the ventricle, so is it coming from the atria or not, like you can see?
Yes, so it's considered an atrial rate. They just,
But it's not the SA node or the AD node, it's like somewhere in the atria?
yeah, it's more or less like that. So you're not necessarily coming from one of those two spots, but it originates above the ventricles. So it originates in the atria. So you should have a P wave. You just can't usually see it because the rate is so fast. Okay. And then the T wave goes the direction of the R, again, because we're not ventricular, right? We're above the ventricles. And so your T wave is going to go the same direction as the R. So why and when? So tachycardia versus SVT. Here we go. If you are a firefighter or you just got off a treadmill Do you have a reason to have tachycardia? Yes. You come out of a burning building carrying somebody, and then you're like, whoa, I'm not feeling so good. I'm feeling a little dizzy or whatever. They rush you to the ER, and you've got this really high heart rate. Maybe it's right around 150. Do you have a reason to have that heart rate? Yes. Yes. Just got off your treadmill. You're hitting that target heart zone, or whatever you want to do, however hard you've been working out, and you've got tachycardia. Maybe it's pushing right up there, 140, 150. Do you have a reason to be tachycardic? With SVT, you can be watching TV, have a respiratory rate that's normal, and all of a sudden your heart goes bam. It doesn't ramp up and ramp down, because when you are tachycardic and you're on the treadmill, do you go from 60 to 140? Or do you go... Nobody runs in your family? Is that the 60? You kind of go 60, 70, 80, 100, 140, right? And then when you're done, then it starts to come back down. You will see that same pattern in someone who's tachycardic if you're resolving the issues. SVT is 60 to 140. 60 to 140. Just like that. It just starts and takes off. There's no ramping up and ramping down. Yeah.
So is the cutoff point, or like, is the rate going to be higher for like kids because their heart rate is so different anyway?
Not usually. So if they have a run of SVT, it can be equally as fast, or it can be faster. So where that range was the 150 to kind of 250, where they're already a little higher, they would let them, before they diagnosed SVT, it would be a little higher than just that 150. If they're a young child who normally has a heart rate 125, it's only 25 different. It might be a fever or something. If there's a cause like that that's driving that up, that is where a lot of the symptomology and the diagnosis is involved. Is there a reason that they are running faster? Does that make sense? If you had a child that just had heart surgery and they had normally all their vital signs had been recorded at about 125 to 130 before they went into surgery, now they come out with an irritated heart muscle and they're cooking along at 200, then yes, they would probably call it SVT, because it's an irritated heart muscle and there really isn't a lot of other reason for them to be going that fast, because they're sleepy from anesthesia and they're just resting. There's no reason to have that fast of a heart rate. Does that make sense? So a lot of it comes down to, is there a reason? I have a friend that has SVT, and she, when it comes on, she doesn't feel good. She'll just lay on the floor and put her feet up on the wall. Because she knows that sometimes she'll pass out. So she just lays down and puts her feet up. She's a student at Weaver State. She's like, yeah, there's been a couple of times where I just walked out of class and laid down in the hall, put my feet up on the wall. Like, no one gets concerned about that. She goes, no, nobody usually comes and checks on me. Yeah. Yeah. Right. Uh-huh.
Because there was one time I passed out and fell off the garage floor while at work. But we had a chair that was kind of high. And I passed out and fell off of it. And they were like, what did you do? All that stuff. But then we just like, oh yeah, it's just anxiety. Yeah. I mean,
But there's kind of a difference between you feeling anxiety and you feeling anxiety. Yeah. So it is very, very common in like teenagers and early 20s. So middle to late teens, they might be in PE, and so it gets written off as, oh, they were they played too hard or whatever, they couldn't handle the activity or whatever. They're not somebody who's usually very active or something like that. But then they're pretty persistent. They're like, no, this was different. This is something that I really felt different in my chest. It felt fluttery, or I felt like a little bit of chest pressure. I felt like my heart was jumping, and then I got dizzy, passed out, felt nauseous, and then have all this other symptomology that goes with more than just being tachycardic. They bring them into the ED, and unfortunately, we hook them up to telemetry and do an ECG, and they sit there for 4 hours. Every once in a while, occasionally you'll see that PSVT, where all of a sudden they'll go zing, and they'll have this run of SVT, and then it's gone. And they're like, yeah, that's what I'm feeling that way again. And then it's gone. So sometimes we'll send them home with a Holter monitor, and sometimes it'll get picked up. Sometimes it's so infrequent that it doesn't get picked up. And then if it doesn't continue to be a problem, which sometimes it's not, then it just kind of doesn't seem to bother them anymore. Then it just kind of goes by the wayside. Like I have a friend who was trying to get a hold of her ex-husband to see if there was a heart history in their family because her son was having this issue and had it twice, ended up in the ER twice. And then they were like, we're going to send you home with a Holter monitor. And that was about a year ago, and he has high thumb sticks. And so I think sometimes it gets misdiagnosed maybe as anxiety or something like that when the person wasn't really feeling that way until the heart problem happened. And then they're like, oh, now I feel really just because this is crazy. What's going on in my chest here? So you will see that commonly in that age, and it can be someone who's in very good shape. My friend that has SVT, she's in very good shape. Walks all the time, she swims, and she just has this problem. Sometimes she can watch TV and all this and just take off. So a beginning and an end. So it ramps up or it suddenly starts. And then the variability. When you're tachycardic, do you run just at 150? Or is it 148, 152, 159? And it's staying right there, right? But it's kind of bouncing around a little bit. That's variability. SVT is relatively unchanged. It will read 150, and it will just read 150. And it won't have that variability in it. So some of those will be ways that doctors look to diagnose more than just tachycardia. Now, if they get up around that ceiling of 180, where it used to be, very seldom do they not say SVT. I do see them sit the fence a little bit at the 150 and really look at these different categories. And really look and say, do we have a reason to have them be tachycardic? Is there some variability? Did it ramp up and ramp down? Yeah. Uh-huh. Uh-huh. Oh, yeah. Yeah, so if you have a run, so you might have a run of SVT. We're sitting there and you're just in class and it's 100 or 115, so sometimes people will run a little tachycardic, just overall. And sometimes they don't. Sometimes they run at 90. But then all of a sudden your watch or whatever will be like, you're running at 147. And then a couple seconds later or a little bit later, then all of a sudden it's gone. And that can be a run of SVT. Yeah. Mm-hmm. Yeah. And then it's gone. Yeah. That's pretty indicative of a run of SVT. All right, so causes can be physical and emotional stress. None there, right? No emotional, physical stress in nursing school, right? It can be bronchodilators, coronary artery disease, hypoxia, and stimulants. Those can cause it. But can they also cause tachycardia. So it's definitely something you would look at and then compare to some of your other categories. Well, they have an asthma attack. Does that increase emotional stress? And then they use their inhaler, and now they're in here, and their heart rate's just cooking along. Would that be tachycardia or SVT? Let's watch it for a little bit. See if there's anything that gives us a beginning and an end or any variability. Okay, so they look at the whole big picture. It's not any just one thing. It can occur at any age. About a third of the cases have no underlying heart disease, and it's the most common dysrhythmia in young adults. They can have palpitations, nervousness, syncopes, and sometimes they'll be in class and they'll pass out. And then they bring them in, just like that. And they're like, well, we need to go get you looked at because, first they'll ask, when was the last time you ate? Was your blood sugar too low or something? And they're like, no, I'm fine. I just went from like 0 to passed out that fast. And I don't know exactly what happened in between. So just know that those are some of the things they would have to look at the whole big picture before they just say, yes, this is SVT. All right, so what's your rate? 180. Who just threw that out there? It's 180, yes. Because when I initially put this slide in here, 180 was the standard. So I just left it. So 180, can you see P waves? Not really, because it's going so fast, right? We're just like T wave and back up. T wave and back up. Yeah. Usually a little bigger and a little rounder is a T wave. So let's see. So if you were questioning if it was a P wave, what would you look at next? That's right, a narrow QRS, and it's narrow. And then your ST kind of comes right back up here, right? We're not hanging out low or coming up too high, so we're good there. T wave, going the same direction. So we're good there. So the only thing that's wrong is it's too fast. So then it's over our 150, right? So we're already going, is this likely SVT? And I would say if you hit that 180, then a lot of the other things go out the window because it's more than just bronchodilators and it's more than just stress. And it's more than just some of the other things that can cause tachycardia. And if there isn't any variability, which you don't see here, then, and you don't see it ramping up and ramping down, right? Then this is something that they would call it SVT. Now, if you saw a normal sinus rhythm, and then this, zing, and then a normal sinus rhythm, that would be what they would call a run of SVT. Okay? If I were to put SVT on the test, it would be very apparent that it's SVT. Okay? I will not sit at 150 on a range. It will be below your gold standard or above your gold standard. Okay, I'm going to give you one that's 150 and then have two options, be tachycardia and SVT. Okay, all right. Okay.
So on that last one, the only way you really know that it's not tachycardia is because it's relatively unchanged.
So it's relatively unchanged. It's 180. You don't see a start and a stop. You don't have like that variability, the relatively unchanged. And it would still be a little difficult without a story. So saying what happened here? What's going on with this?
We just looked at this.
It would be a little difficult. Now, if it was 180, I don't know too many doctors that wouldn't call it SVT. Yeah.
Would it be like spinous?
Would it be what?
Would it be like spinous SVT? Because like regular.
Oh, coming from your sinus node. Well, you can't really see a P wave to call it that. And SVT is just supraventricular tachycardia. So there's no sinus about it because it's coming somewhere above the ventricles. Sinus is only SA node.
Oh.
Yeah. What's going wrong there? All right, so dizziness, dyspnea, palpitations, weakness. When you think about, how fast that's going, is there much filling time? When your heart's beating that fast, is it filling very well? Not feeling, but filling. It's not feeling very well either, but it's not filling very well. And so you're not going to perfuse well. So you're going to have signs of decreased perfusion. So like shortness of breath, they'll be weak, they can pass out. And so along the lines here, they can have decreased level of consciousness a little bit and feel very, very dizzy. They can be a little bit sweaty, have some diaphoresis, and hypotension. If your heart isn't filling very well, how do you, and it's beating this fast, do you have adequate blood pressure? If we can't get enough blood out to the body, and we're not perfusing well, are we going to have a very high blood pressure? No. So that can also contribute to feeling weak, feeling dizzy, and the poor perfusion because you don't have an adequate blood pressure. Interventions, if they're stable, if it's like my friend, laying on the floor, her feet up, you can try vagal maneuvers. But if it's truly SVT, they may not work. They can try. That will help more often with tachycardia. Yeah.
I just get a question, but I am confused about the only difference really on an ECG with tachycardia and SVT is the fact that it's usually higher than 150 and that it doesn't have a P wave.
It's not that it doesn't have P wave, it's just that you can't see it very well because it's going so fast.
Did you say that could be the same with tachycardia or pseudo?
Yes, yeah. So it could be going fast enough that you don't see a P wave very well. And so then you look at your QRS width, make sure that you know whether it's coming from above the ventricles or not. But if that width is narrow, then you know that it's coming from above the ventricles and you can kind of continue on. But that's like how I was saying, if it's significantly above 150, like in that 180 range, then it's more likely to be SVT. People don't usually just run tachycardia that fast, prolonged. Does that make sense? So often you need a story behind it, but if it's far above your gold standard, then they will usually call it SVT.
So if you're going to give us a script for detecting tachycardia, we would call it P wave theory to show there's a sign of tachycardia.
Yes. And it would be below 150.
Okay.
So I would not give you the option to have it be SVT. Okay? Yes. Yes. It's not a to trick you thing. It's something that you just need to learn how to identify so that when you are looking at a strip in the telemetry monitor, then you can go, wait a minute, that piqued my interest. I'm just going to watch here for a few minutes and see what I can identify, see what I can see. I guarantee the next few clinicals, if you have somebody on telemetry, it's going to be pretty interesting. You're going to be kind of glued to that monitor. What can I find? What can I see? What can I do here? All right. If they're unstable, they need meds and cardioversion. And by unstable, I mean if they're hypotensive, they're so hypotensive that they're not perfusing well, or they passed out and they're having level of consciousness changes, they're not really coming back around. Those are some of the changes that you would be considering unstable. Adenosine, remember, slow down. That's acute. So if it's happening like right now, they can give them adenosine, but it's not something they would give them to take it home. Does that make sense? You don't want people doing that. That stuff is their heart rate. You want to crash right around. Calcium channel blockers and beta blockers can be given acutely or chronic. And then other treatments, if they're stable, they can try vagal maneuvers, blowing through a straw, ice to base. You just tell them it's coming. You don't just like cram their head in the ice. Just be like, hang on, we're going to do this. Bear down, and then this carotid massage. I do want you to remember carotid massage is not a nursing intervention. It is something that can be done, but it is very effective if it's done the right way. But you literally, they turn their head to the side and they massage that carotid artery. It is a physician or a practitioner, like nurse practitioner, PA physician, but usually I haven't seen a PA do it, but I have seen several physicians. And it can decrease that heart rate significantly. And so it's something that you're there to help monitor, but it isn't a nursing intervention. And then I've also seen them do it and have it do nothing. So I've seen it be really effective and not effective, but it is something they can try. And then synchronized cardioversion, where they hit it on the top of the airway. And then it kind of resets the clock. Or until you have a mask on, right? All right, ventricular tachycardia. There's a lot of red. It originates in the ventricles, so we already know what's going to be the deal with our P wave. Not existent. Atria did not depolarize. What about our QRS? Wide, just down. It's clear out here. And then your T wave. Opposite from the R. Yes. Okay, so your rate greater than 100, often greater than 140. So remember, tachycardia is over 100. We like things to be in the 60 to 100 range. If you remember from your assessment PowerPoint, where it says 60 to 100 is coming from the SA node, and then like the 40 to 59 is coming from the AV node, and less than 40 is coming from the ventricles. That's a sick heart, right? What do you think about this? That normally, if it's pacing normally from the ventricles, it's less than 40. If it's coming from the ventricles and it's over 100, we're in trouble. We're in a lot of trouble. You can see gone. Like they have been all over the place, or this person has immediately been in a lot of trouble. The rhythm is very regular. P wave, mostly absent. Every once in a while you see if one sneak through, like the atria are still like, well, I'm here. And then it's just ventricular. But I have never seen, like I have people who have said, oh yeah, I've seen a P wave occasionally with BTAC. I never have. So I put it there because I've been told that occasionally people have seen it. But it is unrelated to the QRS. So it's just kind of randomly there. It's not associated with all the other QRS. So your PR interval is not applicable. Your QRS complex is just wide and bizarre because you have all these ventricular beats. Your ST segment is usually unidentifiable because it's kind of slurred all together in those beats. And the T wave, if it's seen, is opposite the direction, well, not of the QRS, of the R, okay, of the R wave. Causes an acute MI. Ischemia, this is profound ischemia. Coronary artery disease, too many PVCs that have gotten closer, and you haven't rectified these problems. Okay? Drug overdose can cause the attack, and trauma to the heart, like a blunt force trauma, somebody who hits the steering wheel in a car accident. That could cause an attack too. All right, so what's your rate? It's pretty fast. We'll go with that. What's your rhythm? 160, okay. What's your rhythm? Very regular, right? Okay. What? It's very regular. So it's not, you don't have like one here, and then one here, and one here. Like it's not irregular. There's no irregular pattern to it. They might be shorter and longer, but the regularity is the same. What are your P waves doing? Do you have any? No. How about your QRS? Okay, so you can go, some people will go QRST, RST, or some people are like, no, that's my RST. I always look at the QR. The R is pointier and smaller than the T waves. The T waves are generally bigger and rounder. Okay. Regardless if that's a P, an R and a T, or an R and a T, they're still going opposite direction, right? We have no P wave, we have a wide QRS, and we have an R and a T that are opposite. So we know that that is a ventricular rhythm. And we know that it's too fast. And so what would you call it? Yes, VTAC. We're going to do tachycardia. Okay? Big problem. Big problem, because now we really aren't perfusing well. Yes.
So, that's what I was gonna ask.
Not zero, but very poorly. Like they're just a smidge above be good. Yeah, slightly alive. Yes. Yeah, slightly warm. We're not more cold, right? We're slightly warm. So it is very ominous though, and often progresses to fever. They'll have chest pain. They can have heart failure very quickly after this. It's very, very ominous, especially if they've had like blunt force trauma, something that has immediately put them into VTAC. If they have PVCs that haven't been rectified with the acid-base imbalances or electrolytes, and they're slowly getting to where they've gone here and there to some couplets, to quadrigeminy, to trigeminy, to trigeminy with couplets, to bigeminy, then you are progressively getting more and more in trouble, and you're not fixing what was causing it. So keep digging. But at this point, then you're going to, they can be impulseless VTAC, they need to be immediately defibrillated. But they can have hypotension. Why? We're going really fast and we're not feeling very good. And it's ventricular, right? We don't have that atrial kit. We have just some passive filling. So whatever little bit of blood has kind of leaked from the atria to the ventricles before the AV valves close is then going out. And it's not got a lot of filling time because it's going fast. We've got several things there, so they're not perfusing well. They can go into shock. They'll decrease the level of consciousness significantly. Literally very hard to wake them up. Yeah. Sometimes, if it's pulseless VTAC, no. But sometimes you'll be able to feel a steady pulse. Yeah.
So from the front floor, is that this, like you just come in and knock everything?
Yeah, and it can cause bruising and it can cause like inflammation around the heart, so pericarditis. And so with that, if you have enough fluid around the heart, then it kind of squeezes and pushes on the heart and causes cardiac tamponade. And with that, you'll cause a lot of these big changes in your rhythm. Yeah. Mm-hmm. She may have, or she may have just gone into defib. Like it may have just knocked out the rhythm. Does that make sense? If she didn't have a pulse and was unconscious and not breathing, and probably defib. Yeah. Which is our next one. That's our next one. But yeah, that can do it. That blunt force trauma. So they're hemodynamically unstable. Their blood pressure's in the toilet. Their pulse is all over the place. They're not breathing well. They're not perfusing well. They're very diaphoretic. Their level of consciousness is such that sometimes it's very difficult to wake them up. They need to be immediately defibrillated. If they're hemodynamically stable, which I haven't seen very often. I have seen a couple of people whose PVCs have gotten closer, and they haven't been able to figure out how to fix that, where they're just kind of being sicker, but they're still sitting there going, I don't feel very good. I feel like there's like, not that it's like crushing chest pain like an MI, but that the chest pressure is getting heavier and heavier. I feel like I can't catch my breath, but they're still talking to you, and they still have a decent blood pressure, and they still have a perfusing pulse. Will they be perfusing well? No. They'll be pale. they'll be diaphoretic, they'll be cool in their extremities. But if they have a blood pressure and a pulse they might be low end of normal, but they are still getting some perfusion, they will call them hemodynamically stable and they'll treat with medication. But I have more often seen them do a cardioversion if they're more haired as opposed to just medication. Like, let's get this covered now, especially if it's somebody who's getting more and more and more and more in trouble. So amiodarone is an antidysrhythmic. That's a medication that they can give them. Other treatments, acute defibrillation and chronic. If they keep having trouble with VTAC, some people just keep going into VTAC, and that is really dangerous. They need an ICD, which is an implanted, I've got there, implanted, like I'm trying to remember, implanted defibrillator cardioverter. The newer ones can pace too. So a pacemaker is pretty thin, just a little bit bigger than a silver dollar, and an ICD is a little bit thicker, but it can defibrillate and it can cardiovert. And then the brand new ones can help pace their heart too. So they're pretty cool. My brother-in-law has an ICD. He was just like reaching in the fridge. I think in really good shape. He's a police officer in really good shape. Bent down to get something out of the fridge and just collapsed. And just never had any heart history or anything like that. Had always gone through rigorous testing and never had any issues, and his heart just stopped. And my sister-in-law did CPR, and when that happens, high quality CPR can save someone. I always keep him that he hasn't lots of brain injury over time. Like, he'll say something and I'm like, Jim, I think you have an lots of brain injury. And my husband said, one of these days that's not going to be it. I just don't think that's very funny. One of these days he's going to take offense. And I'm like, no, I don't think so. I've said it too many times. I don't think he takes offense. He probably doesn't even care that I think that. So anyway, so they're pretty cool. Those ICDs he has one now, and it has shocked him a couple of times. And it really gets your attention when that happens. What's that? Yeah, very hard. Know your algorithms and where to find them. So an algorithm, everybody know an algorithm? Most of the time, there are several that don't. So you have here where you might say VTAC. And then off to the side, it will say, do they have a pulse? And over here, do they not? And yes or no. If they do have a pulse, then you follow this side of the algorithm. And if they don't have a pulse, you follow this side of the algorithm. And so that's kind of how that goes, and it tells you step by step what to do. They have those for all of your heart rhythms that need major interventions, like VTAC, asystole, EFib, it can be AFib, but they have algorithms that are on the crash cart so that anybody can run that code no matter how nervous they are. If you have a physician that's new, they come in and everyone's like, all right, doc, what do we do? And he's like, trying to reach back in the recesses of his mind and try and pull out the information. They have them laminated and hung on the crash cart. And so then all you have to do is just pull it out and be like, all right, no pulse, we're going to shock them. Or we have a pulse, let's do some CPR and do some cardioversion or meds or whatever the case may be. Okay, BFib. There is nothing pretty about BFib. I know, there you go. It originates in the ventricles. There is no rate. It's very chaotic. In the irregular rhythm, if you can even find a rhythm. P waves are absent. Your PR interval is not applicable because there are no P waves. Your QRS is not really discernible as you have this really irregular baseline. It's just kind of a mess. Your ST segment you can't detect, and your T wave you can't detect either. Your causes, everything that has not been rectified prior to this. So if you have somebody who is in respiratory arrest, then you have this very limited amount of time before they end up in cardiac arrest. especially with P patients, most of the time, they start out in respiratory distress. If we intervene, we can keep them from going into respiratory arrest, and that will precede cardiac arrest, because there's only a few kids who will just go into cardiac arrest, and those are kids that already have a heart history. Okay, so kids, if you intervene when they are when they're having respiratory distress, you will often be able to ward off AFib. Okay. So acute MI, ischemia, electric shock can put somebody right in AFib. It disrupts all the electrical activity in the heart. PVCs and VTAC that haven't been resolved, and electrolyte imbalances. All right. So let's look at the top first. What's your rate? 9. Any rhythm? Any rhythm to that? No. Any P waves? Lots of QRSs or not really QRSs, because this is what's happening with VFib. Your ventricles are just doing this. So they're not contracting like this. So you might get a contraction here. That looks a little better than the rest of this, right? Maybe you got one here. But most of the rest of the time, it's just quivering. It's not doing anything. So are they perfusing? No. If someone is not perfusing, what do you see? They're unconscious. Are they breathing? No. Yeah. Nope. No pulse. No blood pressure. No breathing. So if someone were to ask you if it was dyspnea, is it yes or no? No. Not any difficulty breathing, right? It's apnea. Yeah. So no breathing. Not difficulty. There's just nothing. There's nothing happening. They're unconscious. No pulse, no blood pressure, all of that. So you're not perfusing at all. They get pale, cold, dusky, all of that. It's an ugly sight. So the difference here and here, anybody want to venture a guess? It might look a little more regular. They're actually both VFib, but sometimes it's just a different view of it. Sometimes you'll see it a little more rounded. Sometimes you'll see it a little more pointy like that. But your cue is the symptomology, right? Their clinical manifestations, how are they presenting? If they are unconscious, not breathing, no blood pressure, no pulse, they're cool and clammy and cold and pale and all of those things, then this is definitely not an organized rhythm. They definitely need to be shocked. What's that? Oh, okay. All right. So loss of consciousness, absent pulse, absent respirations, and BP. So absent pulse, respirations, and BP. They can have seizures. It is lethal in 4 to 6 minutes. You have got to get a heart rate back in that period of time. Interventions, rapid defibrillation, and you initiate CPR while they're getting the defibrillator and getting it ready and charged. Good quality CPR. Yeah.
So if you talk about we don't know obviously the will that stop the movement? We need an AED to really stop and stop it.
Yeah, so you need the AED because it's electrical. It's the electrical activity. What you are doing is circulating any oxygen that's in there, circulating that blood to feed any tissue, any core organs the best that you can. So you buy them time.
Car battery.
Yeah, kind of a car battery. Here, I think this might work. Yeah, that's where a lot of times CPR, you do the best you can until the outcome. You know, you wait for an ambulance. You do CPR the best that you can until that ambulance comes. But if you do CPR and you do it well and you do it right, how tired do you get? How fast? It's ridiculous how fast you tire. Yes. Do you feel it right then? No. Your adrenaline is going. Do you feel it after? Oh, yeah. Yes, you do. Yep.
So, like, kind of just like that, I took like different times to technically like dead, like, I don't know, it's like, no, wait, no, we can do whatever anything, but, for like 30 minutes, I stopped to get up and I was doing, concussions until the ambulance arrived, and he was like unconscious for 35 minutes.
Uh-huh. Yeah? Wow. That is so fabulous. I have seen little kids that were near drowns, where they were down for a minute, for a while, down for like that, like 30 minutes or so, and they were brought back and they do have significant anoxic brain injuries, but they're alive. Cold water near drowns have better success than warm water. And then obviously when they know the time that they went down, if they find them in a pool or in a lake or something like that, and they have no idea how long they've been down, then they work them for 30 minutes or something like that. You don't know if that's actually an hour. You know what I mean? If they were actually down for 20, 30 minutes, and now we've worked on them 20 or 30 minutes, and we're pushing an hour. So definitely the ones where they know exactly, when they were down in cold water, are better that way. They're sad anyway when you see the anoxic injury. Yes, they're there, but what's their quality of life like? And I think that's something where you have to go, people around you or people who know you have to know how long to work you over if you crash, basically. If you are not breathing, if you've collapsed or something like that and you don't have a pulse, how long would you want somebody to do CPR on you? Or how long would you want them to do CPR on your child or on your loved one? So where we had neurotrauma patients, we had a lot of the near drowns and stuff with primaries, and there were a lot of kids where I'd be like, they came in and they said how long they worked them, and I'd be like, oh gosh, if this kid makes it neurologically, they won't have any what they call meaningful interaction. So they might be alive and breathing, but they don't recognize anybody. They don't smile. They wear a diaper. They have a G-tube. They don't do anything to breathe on their own. They don't have a heartbeat. And what kind of quality of life is that? So that begs some of those ethics. How long do you work somebody like that? Yeah. Okay. All right. Meds. Epinephrine. Get that epi in there. The algorithms will tell you when. Hey, ACLS guidelines say to shock and then give epi. It used to be the other way. But you shock and then you give epi and you follow your algorithms on your crash cart. You shock them, see if you can get a little bit of a rhythm. You give epi and you give good quality CPR so you can circulate that epi. And then defibrillation and CPR. All right, so tell me which you would be more concerned about and why. Top one, okay. Why is that? No perfusion.
It's not really like consistent. Like this one, it's like a little bit more narrow and a little bit more like.
Okay. Okay.
Oh, that's good.
Okay. Yes, there is a right answer.
Glad you asked that.
But you guys have really good thinking. What would you do if you saw this? No. Okay, to be able to check for a pulse, where do you have to be?
In the room.
In the room. Check the patient. Check your patient. Check your patient. Because this is VFib and this is artifact.
Oh, I was gonna say that.
Knew it. This is artifact. So this is the patient that you will walk in the room, you will see this on the telemetry monitor and go, oh my crap. And you'll go running in to see your patient and they're laughing and they're itching their chest and you've got this weed that's all crazy and unstuck from their hairy chest or whatever, stuck to the gown and everything's getting all jostled around. And you're like, oh, okay. And they come in and they're like, no, fine. You're kind of pale. What were you thinking? And you're like, nothing. I'm so glad that this is all what I've had. Okay, so check your patient. Check your patient. Take their pulse. Be at the bedside. But if you see this on the telemetry monitor, do not call a code before you go in and check your patient. We will have 17 people come running to the room just to see your jovial patient, wondering what everybody's doing. Okay? But this is VFib. So if you saw anything that concerned you, or was a change in what you had been seeing, then check your patient. All right, asystole. There you go. There you go. That won't be on the test. But this is my favorite. My husband will not watch medical shows with me. I'm like, you can't do that. That doesn't work. And he's like, shut up. They always wait till here to do what? Shock. Is there any electricity there? No, there's no extra. No. You missed your chance to shock. This is high quality CPR. You gotta get in there and get the CPR done. Circulate, give epi so you can get a little bit of a blip or something back so that you can then go ahead and have someone that you can shock. Will they try anyway? Yeah, they probably will. Even though they know. Yeah, no shock advised. Your AED. If that's what you're looking at, no shock advised. So cardiac arrest, respiratory failure, hypoxia, drug overdose, acidosis. So electrolyte imbalances can bring you to here. High quality CPR and epidural will get you hopefully to where you need to be. All right, pediatric dysrhythmias. We're almost there. Oh, 20 minutes. We can knock this out in 20 minutes, and then when we come back from lunch, we'll do some practice tricks. So we won't learn anything new. We'll practice, okay? So that you can see ST depression and T-wave inversion and all of these different things. Yeah.
Wait, I'm sorry. I've been like not wanting to pass this question because I'm not going to do the question.
No.
When I was little, my mom would always like, and people would always be like, you can't like pretend this is blood. Is that because it's kind of like the thinking of like if you were in a person who had a normal heart rhythm and everything, CPR, it would be like a blood trauma and then you put it into it, like dysrhythmia.
And if you do it right and you break ribs like you often will, you can puncture their heart or puncture a lung. So so definitely not something you should pretend because you might be really good at it. And then they're in trouble. Yes, because then it's one force trauma and ripped up inside. Yeah. Clarify that. So please don't go pretending. Always check for a pulse and any of your other symptomology. All right, so causes for pediatric dysrhythmias. If you will notice, respiratory failure, aspiration has an anoxic injury to it, near drowning has an anoxic injury to it, trauma can. Shock, and if they go into shock really quickly and they're not perfusing because they're hemodynamically unstable, then that can cause respiratory. So you see all the respiratory components there. Now, SVT is not always super common in little kids, but pediatrics extend clear up to 18 years old, right? So some of these teenagers that might have some issues can still be considered a pediatric patient. Nausea, vomiting, diarrhea, why? Electrolytes, yeah. Get those electrolytes out of that. Unrecognized respiratory failure or shock are the most common causes of cardiac dysrhythmias in kids. So if you can figure out those couple of things, and with shock, I mean like septic shock also. So sepsis can be something that can drive this train too. So if you don't figure out those things really quick, then it can progress to this. But they don't often just start out, because the rest of us have had time to ruin our vessels or clog our arteries or whatever, but little kids have clean pipes. And so they don't just have dysrhythmias very often. Bradycardia is a common response to hypoxia and can be life-threatening in children. So know your vital signs. That's why I give you the little badge. Where's some of this coming from? Oh, yes, or something. Somebody in here. Maybe wanted one on their work badge. Yeah. Okay, yeah. I think I have an extra one, so let me see. Bradycardia can be life-threatening, so know your vital signs, know your heart rates. If they're starting to fall, or they fall significantly from where they have been, something that needs to be on your radar. It might be a baseline for an asymptomatic athlete, and don't rule out the possibility of eating disorders in teens. If they have an eating disorder, they will tend to run their bradycardia. Nursing assessment, so level of consciousness, look for dizziness and syncope. Look for any pain. So if they are having, if they have a really bad infection, like in their hip or in their leg, or maybe they had osteomyelitis, so maybe they had femur fracture, and now they have pins in their leg, and they've done really fine, but now they come back in and they're in a lot of pain, and initially they're tachycardic, and now all of a sudden they're becoming more and more bradycardic, and they've got that infection in there. It can be sepsis that's starting to cause that. So looking for pain also. Shortness of breath, nausea and vomiting, diaphoresis, and I would add in here with the level of consciousness, anxiety and restlessness. Because what happens when someone starts to be hypoxic? They get anxious and they get a little restless. And you can't always quite pin it because it's a kid. And you're like, oh, he's kind of irritable, or he's just kind of off. And parents are like, he's not usually dishonoring, and he's not usually, and they just kind of seem like they can't settle. Put a little bit of oxygen on them if you can. Sometimes they won't keep it. And so then have your parent give them a job, have them have some blow by, and see if you can help correct what might be any hypoxia, and see if that will help the anxiety and restlessness. And then signs of poor cardiac output or your tissue perfusion. So with your nursing interventions with your fluids, careful not to overload them. They're just little guys. So give them a bolus if they need, if they're hypotensive. But they will be very judicious with how many boluses they give. And if they're a cardiac patient, it's the same as being a cardiac adult patient, that you can't overload them with food. Oxygen, even if their SATs seem okay, if they're restless and anxious and you can't quite pin them why, then see if they will play with it. Some kids won't let you put it on them, but if you're like, can you hold this by your face, not by my face, not by mom's face, not by your face, or make it a game or something like that. Let me see how long you can put it on your face, and then every time you put it on your face and count to 10, mom will give you a sip of this slush, or something like that. And then it keeps it on there, and then they're like, 1, 2, 3, and they're just sucking in all this oxygen as opposed to just being like, no, I'm not having anything to do with it. So see if you can be creative and make it a game. Meds, if they're tachy, brady, or any antidysrhythmics, monitor their vital signs in labs. Any mechanical interventions like cardioversion or defibrillation. I've only been in on a cardioversion with a kiddo who had an underlying heart problem and had surgery, and there was a rhythm that needed to be cardioverted, and then defibrillated. Thankfully, not a ton of kids. And some with better outcomes than others, unfortunately. But it's hard. It's harder to see. Not that you would wish any adult demise, but it sits a little better, I guess, for me because they've had a chance at life. And they've had a chance to be
a mom or a dad or a grandpa or grandma or, something like that to have part of their life. But then when they're a little kid, you're like, oh, come on. You have so much time left, So really recognize those respiratory pieces before you get to needing this point. Physical, they can do vagal maneuvers. Grade school kids think it's great to see if you can try and poop your pants. I'm not kidding you, they think that's hilarious. They're like, I will give you a prize if you can try and poop your pants. I've never had anybody do it, but they've tried really hard. And sometimes it can bring down that heart rate a little bit.
Their parents are like,
Yeah, the parents like, you're like, just emotional support for the patient and family if they're having heart issues, and even respiratory issues and having dysrhythmias and not feeling well, they need that support. And always assess your patients. Don't call codes and do all kinds of things without looking at your patient. Always reassess the patient after each intervention for their response. Your patient is more than just their ECG. So remember that. Inform the physician quickly of any changes. So if something just seems a little off and you're like, I've been hooked up to this telemetry monitor for a whole day, I haven't seen anything, and now all of a sudden I'm seeing changes. But anesthesia is gone from their system, they haven't had any pain for a while. I looked at my labs and everything okay, and now I'm seeing changes. Something that I need to start digging, and let the physician know. All right, I have a quick video, and then we'll go to lunch. So let's see here. All right, I think I have to initially take it out of this mode. This is okay. Oh, there it is. The what's what of the heartbeat dance. Feel free to dance. There's your ventricles. There's your atria. The music in here kills me. Sorry, it's kind of loud. That off. Maybe that'll help. Atrial contraction, ventricular contraction.
I like to move it, move it. I like to move it, move it. You like to move it. I like to move it, move it. I like to move it, move it. I like to move it, move it. You like to move it. I like to move it, move it. I like to move it, move it. I like to move it, move it.
This hat is great. See the distance? And then there was no keyways. See how far it gets? Further. It better be around. I love his head. It's like an inverted PUA or no Yes. This is a real specific kind of tricky time. It's called facades. So you'll be able to see. CP goes wide and narrow and wide and narrow. Well, that's so big. It's a maggot, man. And they fixed it. All right. There we go. Okay. Were you taking a picture of it? Sorry, did I step right in your way? Okay. So go to lunch, come back at 12:30, and we'll do some practice strips to make sure that that's good and solid. You'll be able to see some ST depression, T wave inversion, lots of different combinations of things. Okay. And that probably won't take us the whole time unless you guys have some questions and need to see some extra ones. Normally, I'll have a document camera and I can slide them underneath and then see them up there, but they didn't equip us with that yet. So I had to put them all into PowerPoints. And so we'll just go through a couple of PowerPoints that have just the slides, okay? Or just the strips. 12:30. Oh, it's just if you go to just by the big staircase by Renee's office, there's a kitchen right there where you guys can warm something up or whatever. Yeah. I don't know if I want to leave this just running for 45 minutes. Oh, thank you.
I told him 12:30, so I bet you could probably like stop it.
Okay.
saw what? You saw what?
No,
People.
I lived in my family members.
So sad.
Like our schedule.
I told him my dad was like,
And you can't leave it like this, so that, you know, online people can mark your class too.
If I could leave what?
Does anybody have questions yet for farm? The chat and stuff, so that we could be, for the online people in the class too.
Oh, yeah. Okay.
I just want to know what the difference is between like legal signing and state.
Okay. Oh, I need my mask off. Yes. The camera's black? Probably not. Sorry. Hang on, you guys. I'm sharing my screen and my camera's on. It shows me.
Oh, Kim.
It's good?
Yeah, sorry.
No, that's okay. I'm glad you checked. All right. Okay, you guys.
Here we go. So the online friends, just ignore the notes that you see there and try and figure out the strips. They can see my notes. So they know what the strip is. So don't look at it and just practice with this. All right, so what's your rate? Count all your R waves.
70.
70, perfect.
5, 6, 7.
All right, now to find our rhythm. E, QRST, E, QRST. We like that, right? Those guys look the same. Okay, so now we're going to find our rhythm off of them.
You keep the same.
PBT. We have an early beat, right?
Premature.
Okay, and then we've got this that looks the same that we like. So we're gonna go kind of back to that same rhythm, and we have an early beat again. Okay, so we know we have premature beats. So our underlying rhythm, what's our underlying rhythm? Yeah, a normal sinus rhythm, right? Okay, then we have a premature beat. Does it have a P wave? Does it have a wide or a narrow QRS?
Earthshake.
My gosh. Okay, so a wide QRS, and then our R wave and our T wave. Yes? Go opposite. So what kind of early beat is that? A premature ventricular contraction. Ventricular because we have no P wave. We have a wide QRS, and our R and our T go the opposite way. Then over here we have another premature beat. Do we have a P wave? And what about our QRS? And R and T? So what do we have? A PVC, right? Do they look the same? So what kind of PVCs? Unifocal. So tell me what you would tell me about this strip. With what kind of PVCs? Unifocal. So normal sinus rhythm with unifocal PVCs. Okay? Does it make sense? Yes.
So what do they call if they don't alternate? So like if your R and your T wave doesn't on your PVC, so you, and because that's another reason it's ventricular. But if they go the same way, what is it called?
If they go the same way, then you're going to be looking more like this. And so in a normal beat that's not ventricular, your T wave and your R wave should go the same direction. If it's
But
not
that's in,
ventricular.
like, the PVC section. So does that ever happen where your T is going to drop and then also your T wave drop?
No.
Never happens.
So you'll have, because you have another ventricular depolarization here, it had to repolarize.
Okay.
Yeah. Yep, good question. Okay.
Let's see here. I do it that way. Okay. All right. So what's your rate? 70. So we're in our 60 to 100, right? So we're good? Okay. And then what's your rhythm? We don't have any really wonky looking beats. So we're okay to probably figure our rhythm, right? Just like this. So what kind of rhythm do we have? Very regular. Okay. What about our P waves? Do we have one or many or what? Many. We have many P waves. All right. So here we have a P followed by a QRS. Is it narrow or wide? Narrow. And then we have what looks to be like a T wave. And then a couple more P waves. All right. So tell me what this looks like. Like, does it have a description to it? What's that? Well, it doesn't make you flutter. I didn't ask you to diagnose it yet. But what I meant was like the sawtooth. How you took the saw on its side, and it kind of looks like a sawtooth. Or more like the guy that was dancing, he's like this, with the flutter. So you've got the flutter waves, okay? And then you've got, it's kind of a 2 to 1 and a T wave, 2 to 1. So there's a little bit of a pattern to it. So when you're thinking about atrial fibrillation and atrial flutter tends to be regular, right? Tends to have a little bit more of a pattern to it. Okay, so you're right, it's atrial flutter. And they would say like with a 2 to 1 conduction or a 3 to 1 conduction, depending on whether you were going to call that a T wave or not. Okay. What's that? Did you have?
We don't even know if it's like a 2 to 1 or 2 to 1, right?
Right, you don't. Nope, you don't need to know that. Okay, so we're going to look at the top. Well, you can kind of see it in the bottom too. You'll see how this says 2. That's a 2 lead. So you'll be able to see what I'm looking at in the 3 lead too. But what's your rate? So if this was a 6-second strip, you've got 1 here, 1 here, 1 here before the 3. So you probably have 3 more, right? It just got, the AVL lead gets really crazy, so I just blocked it out. So probably about 60, because this is only a 3-second strip and we have 3. So we're in the 60 to 100, so we're okay there. When we're looking at our regularity, we've got an R wave right here, and an R wave here, and an R wave here. So it has a crazy little P wave something or other going on, but our QRS and our T tells us that this is not like a ventricular beat, right? Even though we can't identify the P wave real great, it kind of looks like just a little one there. So do we have a regular rhythm? Does it look pretty regular here? Okay, and then hopefully we would see another one there. And then what about our QRS? Is it narrow or wide? They look a little different, but they're not. But if you were wondering, your P wave, narrow QRS, and your T wave is going what? Same direction. So we know that's coming from above the ventricles. And it's a regular rhythm, and we have P waves. So they don't look quite the same. So if wandering atrial pacemaker was an option, then you could use it. But I would tend to call it just a normal sinus rhythm. Now, let's look at our ST segment. So here's your isoelectric line. What happens with our ST segment there? It doesn't come all the way down, so it's elevated, right? And see how over here it's elevated also? It means it's that ST elevation MI. That's what a STEMI looks like, is you'll have that. So it may go down and shoot back up high, or it may just never go all the way down and stay high. So like this one here, see how it goes down and then it shoots up? This is a different view. This is your 3 lead. It's upside down, but it can see really well that tombstone. Look to it, and that's your T wave coming off the side of your ST elevation.
So up here, your ST elevation just never comes and just never comes back down, and it stays elevated. So that would be a normal sinus rhythm with an ST elevation or a STEMI. Okay. That help you have a little bit. I think I have a couple others that have, but that's kind of what that looks like. All right. What's your rate? 80. Okay. And then let's look at our rhythm. So we've got kind of a wonky beat in there, so we need to look at our things that look the same. We have our P, that's kind of crazy here, QRS, T, T, QRS, T. So they look a little crazy, but they all kind of match, right? So that's going to be our underlying rhythm. So then we'll look and see, is it regular? Okay. And then you get here and you have an early beat, right? Okay. So with our early beat, I don't know if I'm in the way of the camera there. Do we have a P wave? No? What about our QRS? Y? And our R wave and our T? Opposite. So what do we have here? A PVC. Okay, so there's something else I don't like about this rhythm. Can you guys figure it out? Okay, your T wave is looking kind of high, but why? Here's your isoelectric line. So that T wave does look a little bit high, but what's here? See how it's kind of sagging down there? And it's slow to return back to the baseline. How it's kind of scooped instead of just coming right back up and going across to the T wave. So that's your ST segment. It's kind of staying, kind of see how it's hanging out down there. I don't know if they can see that very good on the camera. Like over here where it stays scooped. So that's ST depression. What does ST depression mean? Do you remember? So STEMI is going to be elevation. That's acute injury. It's happening right now. We need to get on that quick. But underneath is ischemia. And it's older ischemia. It's not brand new. It's not happening right this minute. Okay? So you would call this normal sinus rhythm with ST depression and a PVC. But that's 3 parts, so don't panic. Some of these practice ones have what I want, but they're all in the same one, okay? So it will either be normal sinus with a PVC or normal sinus with an ST depression, okay? It's just that the practice ones have more things in them. Okay. What's your rate? 180. Good guess. All right, so 180. So then what about our rhythm? Very regular, yeah. Can you see P waves well? You can. Pretty good there, huh? Maybe a little bit, that one's kind of washed out, but then you can see. So if we were questioning whether they were P waves or not, what would we look to next? Yeah, wide or narrow on our QRS. So is our QRS narrow or wide? Narrow, okay. So we know that we must have a P wave because that's a narrow QRS. It's going to come from above the ventricles. Then you have your T, that's a big T wave. So, okay, your QRS, or sorry, your ST segment, it comes right back up to that isoelectric line, so that's okay. What about your T wave? It peaks. What does that mean? Electrolytes. Check your labs. Yeah. So it kind of, if you just look at where, like your P comes up from and your Q is usually right about where it's at. Yeah, uh-huh. And so it kind of falls right, you see the shadow of my finger? Yeah. And it just kind of goes right through there. And then you have your positive deflections and your negative deflections. So with it being there, your T wave is about half the height of your R. So that's one that I would definitely look at my labs, for sure. Okay, and so you have, so what do you have here? Well, it can. So you can have SVT and one of your causes be your electrolytes, right? So that could be something that might be underlying, might be something that you need to look at. You're like, wow, that's looking like SVT. Let's see if we have a reason to have it. Sometimes there is no reason, right? We can look and we can go, no, labs were fine, but we have SVT. Or we might look and go, yep, we've got some hyperkalemia. Maybe that's an underlying factor in our SVT. Okay, so if you have SVT, it won't sit the fence. Okay, and we won't have options that would confuse you. All right, I think on my slide it just says SVT, but those of you guys at home, that looks like a peak T wave. Okay. Okay. Wow. Wow. Okay, so what's your rate? 50. So too fast, too slow, or on time? Bradycardia. Okay, so we've got bradycardia. So now we look at we want to look at our rhythm. So with our rhythm, we want to look at our P waves that look the same. Does that look the same as that? Okay, does that look the same as that, and that? Okay, so those that look the same are going to be our underlying rhythm. But we know that one's probably a little different because that P wave looks different, not coming from the same place. So from here, so let's look at the ones that we have the most together to develop what we think our rhythm should be. Okay? So here to here, here to here, it's probably going to be a very regular rhythm, right? So we're looking at our regularity there, but what would be happening here? Do we have an early beat?
Yeah.
Okay, so we have an early beat here. We know that it's different from here because of the different P wave. Since we have a P wave, where is it coming from? The atria. And a narrow QRS, right? Our ST segment, what's happening there? See our isoelectric line? What's happening? Yeah, it's delayed coming back up. So that's a ST depression. Then what happens with our T wave? It's still inverted. Do we know that that's not a ventricular beat and that it's an opposite direction because we have a P wave and a narrow QRS? That's telling us it is not a ventricular beat. Okay, it's coming from above the ventricles. It's an atrial beat. Otherwise, this wouldn't have depolarized. So that's how you can identify that it's T wave inversion and not an opposite direction making it a ventricular beat. Plus, it happens all the way across. It's not just on that one beat. Okay? So this early beat, what would you call this early beat? Premature? I heard it. Atrial contraction. It's PAC because it has a P wave, narrow QRS, okay, and our T wave would have been going in the same direction, but it's inverted on this slide. So I'll help you. Sinus bradycardia with PAC, yep, ST depression and T wave inversion. I love this slide because it had like so many things. I was like, yes, I need a good ST depression. Oh wait, that's T wave inversion. oh my heck, it has PEC. This is pretty cool. So then you can just pick out the different pieces, okay? And so don't get overwhelmed by it. On the practice ones, I will help you. Yeah.
Can you repeat all that?
Mm-hmm. So your rate is too slow. So you have a sinus bradycardia. Sinus, because you have these normal, nice round P waves that all look the same. So they're coming from the SA node. Then you have this one early beat that looks different. So it's premature, but we know that it's atrial because there's a P wave and a narrow QRS. That's telling us that is not ventricular. So it's a PAC. But then we have to look, now we've done P, we've done QRS, now we need to do ST. ST is hanging out down here, right? So that's ST depression. And then when we get to our T wave, oh, our T wave is also down here. It's inverted. It didn't come up and go here. They will often travel together when they're low because they both mean what? Ischemia. Mm-hmm. Yeah, they both mean ischemia. If you see both of them, that's obviously collectively more ischemia than you would see if you just had some ST depression or a little bit of a blip of T-wave inversion. That's one of the reasons why I love this slide. Yeah.
So sinus just means for rhythm, not for rhythm.
Sinus is your P wave coming from your SA node.
But it's for rhythm, right? Not just rhythm.
No.
Because you're saying it's sinus bradycardia, but sinus rhythm.
Sinus is your P waves that are all coming from the SA node, that are all coming from the same place.
Okay, so it could be anything that has a P wave in its sinus.
If it has a P wave, but they're all kind of looking different, all of them, then you know they're coming from different places in the atria, and they're not all SA node. If you have a pattern that's very similar, that has nice equal round upright P waves, one before every QRS, that's all the same, that will be sinus. It will come from the SA node. So it would be equally as okay to just say bradycardia, if that's less confusing to you. Yeah, to just say bradycardia. And just knowing that if you were to say sinus, it is basically a trend or a pattern that you can see that has very similar little packages, and they all look the same with the P, QRS, and T. Okay. And this, I will post all these examples. I just don't want to post them ahead of time because I didn't have a student copy that I want you to. I wanted you to learn it. All right. So what's your rate? Count all your R weights. 90. Yep. Okay, so let me ask you this. 90 is in your 60 to 100, right? So theoretically, are we okay? Theoretically. Okay, so you saw where I was going with this. What are we perfusing at? 1, 2, 3, 4, 5. Yes. They're perfusing at 50. Is that bradycardic? Yes. Might you see some perfusion issues? You might start to, especially since you're having a lot of wonky beings. That's one of my favorite words. But okay, so to find our rhythm, we're going to find the P, QRS, and T that look the same. P, QRS, and T, that looks very much the same as this. It's got a little blip there, so might be a little bit different. Well, that one does too, and so does that one. But we have all the parts that we would want in a beat, right? Our P, QRS, and T. So you can develop your rhythm off of those beats. So we'll go here and here. Do we already have an early beat? Mm-hmm. And if we travel to here, another early beat. To here and on. Okay, so then we want to look at our ST, comes back up pretty quick, and our T wave. We're happy with that. Okay, so then let's travel to our premature beats. So premature, so if you do that on the test, rate, rhythm, P, QRS, ST, and T, then address your early beats or address anything else that's wrong with them. So travel all the way through those, okay? Now we're gonna do early beats. Is there a P wave? Nope. What about our QRS? And our S and our T? Opposites, okay? So it's very, remember like the guy that did the dance and his legs like clear out here? That's kind of what that looks like. Okay, so what do you know about this beat? What would you call it? A PVC. Okay, does this look also like a PVC or a PAC? A PVC. How about this one? PVC. And how about this one? Right, because none of them have P waves, right? It would kind of be right there. And that's your T wave. But if you wondered, and just look here, wide QRS and your R and your T. So so there's 90 beats per minute. So we would call it multifocal because they're coming from different places, right? Yeah. So this one matches that one. That one matches that one, but they're not all the same. So you have two areas in the ventricles that are angry. What's that? By Gemini? It is by Gemini.
So then can it be both? Can it be, so unifocal or multifocal, and then it branches out into quad, tri, and bi?
Uh-huh.
Okay.
Yep. So you have our multifocal PVCs. So you have normal sinus rhythm with multifocal PVCs and by Gemini.
Only PVC that branches out into quad, or not PAC as well?
PACs don't usually.
Okay, so
Yeah.
only.
Yeah. Every once in a while, you might see a couple of PACs, and then you won't again. Like it's pretty rare to see them. Yeah, good question. Okay, that one makes sense? Yeah.
Same question. Are these packages available for us to like look over or no?
Not yet, but I will. But I'll put it on there. Yeah.
Question.
I just didn't want you to cheat. Didn't you hear that? I didn't want to post it and have you cheat. Okay. What's your rate? Any particular rate that you can guess?
I just typed it in the chat.
What's that? So they'll be posted?
Yeah.
Oh, perfect. Yeah. Yes.
Like Amy was saying, just remind you to repeat the question so you guys can.
Oh, that's right. That's right.
I just
Thank you.
typed it in the chat.
Oh, yeah. Thank you. Okay, so we've decided really not much of a rate. Any kind of rhythm? You guys are looking awfully hard at something that is not there. So there really isn't a rhythm. Do you remember when the guys were dancing and they're like, their arms were here and they were here and they were here? And they said it's torsades and it goes like this. So this isn't it, but sometimes it'll be wide like this and then it'll go narrow and then it'll go wide again. But you will see a very definite pattern to it to know that it's torsades. And it's not super common to see it. Okay, so no rate, no rhythm, any organization, any P waves, any organized QRS or T. So what would you call this? So atrial fibrillation is going to have what? T wave.
Oh, T wave, that's right.
Atrial. Right, and it'll be narrow. You're right. B-fib. B-fib. Just all disorganized. There really isn't any rhyme or reason to it. Okay. It's scary when you look at that and go, I'm gonna look at my patient. Because if you see that and you're not really sure, like I'm not really sure what that is, but I'm gonna look at my patient. And then you're gonna find them not breathing, no pulse, no blood pressure, blue, gray, mottled, whatever, unconscious. And then please call code super fast and start CPR. Okay. Okay. So what's your rate? 70. Okay. So we're in our 60 to 100. So not too fast, not too slow. We're good. All right. So then our rhythm. So we're going to look. We have kind of P's, QRS's, and T's throughout the whole thing, right? So we'll just go ahead and start here. So that one kind of misses. And then these seem to be very close. So it's not, so it's irregular. And it really doesn't seem to be a pattern to the irregularity. If we kept going, we might see a pattern, but in this 60-second strip, you don't see a pattern to it, do you? Okay. No, go ahead.
Well, you say like look for the ones that have similar T waves, right?
Okay.
That very first one, then not the second one, but the third one, they look okay, the T waves different.
Dang it. Well, the T waves aren't going to necessarily be something that you would care about. Well, would compare as much as you would compare the P
So
waves.
then the first one and the third one, those look similar. So if you put those in these as your rhythm, then it kind of matches up a little bit better.
Okay. First, third, and fifth.
Yeah.
All right. So then our second looks different by kind of by itself, or maybe like here, huh?
Yeah, second and fourth one.
So would you take your rhythm from second and fourth, or from first and third? Or would you just call it irregular?
I
Why would you call it
Irregular. Yeah, you does. So then look a little further. So does that one look like any of them? Not really. And it seems to fall a little bit earlier than the others, but this one's even earlier. Does it look like that or like that? Are they all looking just a little different? There's some that are similar, like this, and then like this and this. But that one's a little rounded and a little further from the others. And that one's rounded and further, but it's closer together. And that one's pointed like back at the beginning. So something's going on with our P waves. Right. So we've got an irregular rhythm. What about our QRSs? Are they okay? Narrow or wide? They're narrow. Okay. And what about our ST segment? It looks okay? All right. What about our T waves? T waves are good?
Yeah.
We really can't find much of anything wrong except that it's irregular and our P waves, even though there's one for every QRS, don't seem to be coming from the same place, correct? What would you call that? Irregular. So sinus would be if you have some semblance of similarity between multiple PQRST little packages.
Irregular heart rate.
Okay, it's an irregular heart rate. But what about your P waves? They're kind of wandering throughout the atria. Yes. Wandering atrial pacemaker. Yeah. If you can't really find anything, but your P waves are just like, they're just not quite all the same and it's a little irregular, then that's going to be all that it is you're wandering atrial pacemaker. So, yes.
Like, let's say we're not getting into it that much, right? So you're saying, okay, first, second, third, and fourth are roughly the same. So I'm going to take my rhythm from those and I'm going to say, that's fine. I get to the sixth or whatever you want to call that. And it's early. Well, then the next one's even earlier. So how are you differentiating? If I confuse myself and I say that the first four are the same rhythm and I'm measuring that out, how do you not confuse it with a PBQ of like a couplet? Okay, well now I have two that are irregular and early.
Right. So the question, let me rephrase. for our online people. If you are measuring your regularity with these first four that look fairly similar, how would you not think that those are early beats, correct?
Yeah.
And what early beats they would be?
Yeah, I never saw that.
Okay, perfect.
Two in a row that are early,
Mm-hmm.
that don't match the rest. Like a-
Yes. So two in a row that are early that aren't part of the regular rhythm. So let's go with that. So if we went here and said, yeah, these look enough the same that I'm going to count my rhythm from this. So I'm going here, 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 and now that looks early.
Mm-hmm.
And again, that would be early.
Mm-hmm.
So I'm thinking, what if I have two early beats here? Then what would you look at next? Okay, what kind of early beat? So what are you going to look for first? Okay, it has a P wave, so it can't be a PVC, right? A pendicular was what was going to come out of my mouth. A premature ventricular contraction. So it has a P wave and it has a narrow QRS. ST is good, T is good. So if we were thinking those might be early beats and they might be coupled, we would have to know that they were PACs, and they don't, it's so rare that they couple that you probably won't see it. But if you did and you saw these, they look very similar to some of the ones that you said were in your regular rhythm. And a PAC comes from a different place. So you would have a different look to a P wave that you wouldn't have seen on your other waves. Okay? Does that help? Okay. All right. Yeah. Yes. So what her question was all of the P waves with the WAP, with the watering atrial pacemaker, all of the P waves look very similar, except on the one that is a PAC, if it was a PAC. But with watering atrial pacemaker, they can all look just a little different. Okay, or you might have a couple that are similar and a couple that aren't. But the different beat isn't just associated with something that appears to be early. Okay, if it's wandering, you will see multiple P waves. What's that?
And then the real question is, are you gonna have like a question like that on the exam, or is it gonna be more like?
If you have a wandering atrial pacemaker, they will not be this similar. Okay, so you might have one that's notched or one that's flat, or that there definitely is a bit of a difference in your P waves. This one is just some subtle differences. Sometimes it's hard to find, like you put in Google wandering atrial pacemaker and you get SVT and you get all this stuff. What's that? You get all these things. I'm like, no, I said wandering atrial pacemaker, PVC couplets, and like, that's not what I put in. And so then if I only find like two wandering atrial pacemakers and one's really good and I want it for the test or something or for an example, then I'll use the one in lecture that maybe it might not be quite as great, so that you have the better quality one for practice or for lectures, or I mean for tests or something. All right. All right, what's your rate? 180 plus. Definitely up there. What's your rhythm? Very regular. Okay. So then if we did the same here, very regular there also, right? Okay.
Yeah.
So then do we see any P waves in either of them? Okay. What about your QRS? Wide or narrow? Wide. Okay. Wide on the top? Any different? Wide on the bottom? Okay. Little bizarre. Okay. So we know that our PVCs or our ventricular beats can be a little bizarre. All right. Okay, ST, any ST segment that you can see, or is it kind of slurred in there? All right, any T waves that you can differentiate? If this is your R, what is that? If this is wide and has no P wave, what are we calling it? What kind of beat? Ventricular. So also, with your ventricular beat, you have your R and your T that are going OT. No P wave, wide QRS. So the R and the T are going opposite each other. And so somewhere in here is going to be like R and T is basically all you're seeing, because the ventricles are depolarizing, 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 depolarizing. Remember just these legs? There's no going on. Okay, so it's fast, it's organized, and it is ventricular. What would you call it? VTAC. What would this be?
Yes.
Yes.
Oh, I thought you
Hard
said
problem.
the same.
No.
Oh, okay. So not VFib, it's actually VTAC. What is it not?
It's not regular.
It is if you count. Now that's a little wider, but it looks different. Like there's almost this delineated mark, right? And then this all looks the same. This all looks the same. So it's very regular with what looks the same. Like this. And then all of a sudden, you're like, whoa, wait a minute. Now we're exactly here. So it's very regular, it just appeared different. So when you look at it, are there any P waves down here? No. You have a wide QRS? Even in both different kinds, right? It's a wide QRS. What?
Is that like trying to grip itself?
Yes and no. It can be, what they call it is monomorphic and polymorphic, and it's all VTAC. And the only reason, and that won't be on your test, that's not one we covered, but when I noticed it, when I Googled VTAC and I wanted a slide for it, then I saw the polymorphic one and I was like, oh, that actually, what you see is it's very fast and it's very ventricular. And then it shifts in how it's looking, but it's still regular, very fast, and very ventricular. And so it's just appearing different. But you see how it starts to go back to the other way that it looked at the beginning? And so you might see some shifts. And so all you have to do is walk through that and say, okay, it looks a little different. Do I see P waves? Am I curious why? A T wave going the opposite direction? Yep. And yet. So even though it looks a little different, it's still VTAC. Most of the time, you will see it be very uniform. Okay, that's why I don't necessarily cover in lecture that it's going to be different. And if you were to see VTAC, you will either see like this or like this. I'm not going to give you one that's shifting. Okay. Up here. Basically what it's doing, so you have your, you've got your T, let's see, let me look at it, sorry, right in front of you. No, you're fine, you're fine. Yeah, I see what you're saying. And so you may very well have some ischemic changes, or like have, sometimes when they're in VTAC, they also have ST elevation, where they're having a STEMI, so they're having an active heart attack, and that's forcing them to be in VTAC. And so you may not be able to see, like you can hear a little bit, but here when it shifts, then you can actually see what might be ST elevation a little bit better. Is that your question? Like, are you seeing something else besides VTAC? Yeah. It's what?
I just know, like, this coming on and
Yeah. So, no, you're fine. So usually what it'll be, sometimes when you're looking at these other views, this is probably a V lead, and the V leads can pick up electrical activity going different directions. And so sometimes when you look at them, that's why I always look at the 2 lead, because they get a little crazy when you're looking at other leads. And that might be what's confusing you a little bit. But I do think that there might very well be a little bit of an ST elevation there. And maybe that's why this strip is VTAC, because they are having a STEMI, where you couldn't see it quite as well here, maybe a little bit. But yeah, that's definitely a good pickup. So it is more than what you were seeing here. I think you're having a better view, but I think it's a V lead too that's looking at electricity from different parts of the heart. Okay. Yeah. On an ECG, if you're looking, like, you can change a telemetry strip, so what you're seeing out at the desk, to be often they are 2 leads. If you are seeing something way different than what you've been seeing, somebody's probably bumped it and you're looking at a different lead. So when you look at your telemetry strips, put it in the one that you read the best, which is often the 2 lead. This may very well be a different lead, because it's looking more like it's upside down, looking more like you've got different things that you wouldn't have been seeing here. So that's kind of the nice thing. So if you were seeing this, you definitely want to be mobilized into action and getting an ECG for sure. And then you're going to see all those different leads. And then you'll probably see something like this in another lead. Okay. All right. So we'll compare. There are 2 different things. So let's take the top first. What's your rate? 70. Okay. So we're 60 to 100. We're good. All right. Now P waves. Or sorry, rhythm. All right. There you go. Okay. Very regular. For those of you that didn't pick up on that, very regular. Okay. What about our P waves? Do we have one or do we have many? Many. Multiple P waves. Okay. So kind of put that in the back of your mind. I have multiple P waves. QRS, narrow or wide? Narrow. Okay. What about my ST? It might be a little bit depressed, huh? This one kind of hangs out a little bit. Might be a little slow to recover. Same there. So you have this one you can see a little bit better. Q, R, S. And then that little line that's coming up to the T wave, that's segment. It's your ST segment. So what you like to see is that it comes right up. This one kind of blips up. And here it looks a little bit like it, almost like it hangs out a little bit. So this one's kind of wonky because this one goes down and just pops right back up. That is probably a P wave that you see popping up there because it doesn't normally do that before your T wave. You're seeing an extra P wave. So with here, usually you would see that S and then it just comes back up to a T. And that segment, or this segment here, is what you would see as an ST segment. If it comes right back up to the line, that's what we like to see. If it hangs out and looks a little bit like a cup or like a U, then you've got some ST depression. And that can be indicative of a ischemia. All right, so we have multiple P waves. QRS is narrow. ST segment might be a little low. What is our T wave doing? Can we see a T wave in there? The P's are kind of taking over. Yep. Okay, so what would you call that? Atrial flutter. What makes you think flutter over fib?
Because the regular rhythm.
Okay, it's regular. What else? It looks a little bit like the sawtooth, right?
Yeah. And
Very
they're
kind of fluttery.
The keys are kind of similar, they're not like all different, they're all kind of.
Right. So that is a trill flutter. So let's look down here. What is your rate? Oh, we're done. So we'll do this last one here. Okay, so 90. So we're in our 60 to 100. We're good. All right. And now what about our rhythm? It kind of is irregular through the whole thing, right? Does it look like there's any pattern to the regularity? Irregularity. No, because it's kind of skinny here, wide here, wider, skinny, wider, skinny, skinny, wide. So it really is just irregular. All right, so then what about our P waves? Do we have one or many? So you have this, and when you have a pretty thick line like that, sometimes you have lots. Okay, so we know we have at least that many, right? At least like 1, 2, 3, 4, 5, 6, and then maybe one that happened here before our T wave. Do we have a narrow or a wide QRS? It's narrow, perfect. And then what about our ST segment? Comes right back up there. That one looks kind of a little funny, but it isn't accompanied by any others. Oh, except that one there. So it kind of hangs out a little bit. So some of them might be a little bit low. So looking at a cardiac history might be a really good idea to see if they have any other changes that might have accounted for them being ischemic. So what would you call this one? AFib. Yeah, AFib. What are some of your giveaways?
It's irregular.
It's irregular.
It has non-uniform P waves.
Non-uniform P waves.
And it could have a P wave system atrial.
It does have to be atrial, and it has a narrow QRS. Yeah, so it makes it atrial. So when you look at these two together, see how it's more sawtooth and fluttery for the flutter waves, and a little more fine here, like this, for the atrial fibrillation. And just remember that they're not real contractions. It's just shaking, it's just fibrillating. And so that's where you'll see it be a little bit more fine in there. So I actually have another PowerPoint of practice strips. So I will post this one and the other one. Then on Friday, when I do the review at 9 o'clock, I have another one that just has like 8 slides. And I'll go through it on the review and record that. So take a quick break. I think Debbie's coming to do something. Mm-hmm. Yes. So I think she'll be in any second. She asked me at lunch if I would be ready. Take 5 minutes and I'll go get her. This classroom for pharmacology? I do not know. That is a good question. I would say yes. Well, for right now, absolutely it has to be this classroom because you're the only ones that have the plexiglass. So yeah. But I don't know if that will change. All right, big blue button friends. I'm going to post this, and I'm going to post another practice strip, PowerPoints. There are practice strips 2 and practice strips 3. And then at 9 o'clock on Friday, I'm going to do a little review. You are welcome, you guys. And then Debbie's going to come and do her little Q&A or review or something like that, Q&A here in just a minute. So I'm going to have her title another conference, just pharmacology Q&A, and we'll get out of this conference. So just watch for that. Have a good day.